एकत्रित हैं अपने द्वितीय दिवस पे, और आज भी हम लोग बहुत कुछ जानने वाले हैं, सीखने वाले हैं। और क्योंकि समय की एक सीमा है और हम सभी लोगों का ये दायित्व बनता है कि हम समय का सम्मान करें, जो समय की सीमा हमें दी गई है हम उसका पालन करें। तो अब मैं ज़्यादा बातें नहीं करना चाहूँगी और आप सभी के समक्ष आमंत्रित करना चाहूँगी हमारे बीच उपस्थित डॉक्टर अजीत कुमार सिन्हा सर, who is the Honorable Chairman of the Scientific Committee of Ccdsicon। एक बार शानदार तालियों से चलिए आइए उनका स्वागत मंच पे करते हैं। और अब हम लोग अपने साइंटिफिक प्रोग्राम का इनॉग्रेशन अजीत सर के इस भाषण के साथ करने वाले हैं, और आज वह अपने मन के विचारों को, अपने दिलों की बातों को अब हमारे बीच रखने वाले हैं, व्यक्त करने वाले हैं। तो बहुत बहुत स्वागत है सर आपका मंच पे।
Good morning and a very warm welcome to one and all. I bring greetings for you all from the land of the great poet Rashtrakavi Ramdhari Singh Dinkar. Today I feel extremely glad to welcome everyone to this much awaited conference of CCDSI as it marks the 7th year of its inception. It gives me immense pleasure to be standing in front of you all amongst the most esteemed personalities of the medical field who have won accolades in their respective fields. Sir, Bugusarai is honored to play host to such luminaries. CCDSI, as you all know, was established or formed on 14th of November 2016 on the World Diabetes Day, and it was conceived, conceptualized and delivered by the legendary Dr. Professor A.N. Rai from Gaya. A big clap for Dr. A.N. Rai, sir. Mukta had already detailed about the activities of CCDSI, so I would skip that portion, and on behalf of the organizing committee, I once again extend the warmest welcome to all delegates, faculty members, and office bearers of our esteemed society. Dear members, from the day this annual conference was allotted to Bugusarai, the organizing committee, under the able leadership of Dr. Pramod Kumar Singh, Civil Surgeon and Chief Medical Officer of Bugusarai, and suitably supported by young energetic cardiologist of Bugusarai, Dr. Sumit Kumar Verma, has left no stones unturned to make this conference a huge success. Each and every member of the various committees formed have contributed to the maximum for the success of this Congress of Doctors of Bihar and Jharkhand. Now a few words about the scientific program. The program has been totally prepared by none other but Dr. Sumit Kumar Verma with some inputs from my side. Dr. P.K. Singh had seen to it that the important topics are covered and put for discussion. The topics are bound to keep you engrossed throughout the conference, and you may hardly find time to breathe. Amongst the galaxy of speakers who have come to deliberate on various pertinent topics, may I take your liberty to name a few. We have stalwarts like Professor U.R. Rai, Dr. Ajay Sinha, Dr. Om Kumar, Dr. Amitabh Banka, Dr. Abhishek Kumar, Dr. Sehwal Guha, Divendu Bhushan, Dr. Nishant Kumar, Abhishek, Dr. Sudhir Kumar, Dr. Neerav Kumar, Dr. Samshad Alam, Dr. Pankaj Hans, Dr. Harshvardhan and Megha Sehgal from Patna. We have legendary Professor Dr. A.N. Rai sir and Dr. R.R. Verma and Dr. Mrityunjay Kumar Singh, Dr. K.K. Lohani and Dr. Neeraj Kumar from Gaya, Dr. N.C. Singhal, Dr. A.K. Arya, Dr. Abhay Krishna, Dr. Virmani sir, and Dr. Umesh Khan sir from Jamshedpur, Dr. D.P. Khaitan sir from Ahmedabad, Harneet Singh Bhatia from Delhi, Sahil Sareen from Jalandhar, and Sankha S. Sen from Siliguri, P.K. Agarwal from Katihar, Rajiv Ranjan from Chhapra, J.K. Panda from Cuttack, Sudhir Chandra Jha from Darbhanga, Dr. Prabhat Kumar Singh again from Darbhanga, Dr. Chandramohan Beliwal from Dehradun, and E. Prabhu from Chennai, R.K. Modi from Purnia, R.R. Chaudhary sir is from Delhi, and K.S. Jha sir from Betia. So we have speakers from all over the country. I would fail in my duty if I don't specially welcome Professor Dr. A.N. Rai, Founder Chairman CCDSI, Dr. A.K. Virmani, President CCDSI, Dr. Mrityunjay Kumar Singh, Secretary CCDSI, Dr. Abhishek Kumar, Secretary CCDSI Bihar and Jharkhand. I would request you all to clap for all these dignitaries. My team shall remain ever indebted for their unflinching support for this mega event. I may have missed names of some of our distinguished guests, for which I render my apologies in advance. With these words of welcome and with your permission, I, on behalf of my team, declare this conference open. May I request each one of you to give a big round of applause for the success of this educational feast. Thank you so much. Thank you, sir.
Thank you so much, sir. It was an absolute honor to have you over here as a very integral and significant part of this event. And I would request all the people, all the honorable dignitaries, along with all the delegates who are present on this wonderful occasion, to kindly put your hands together for sir. एक बार शानदार तालियां आनी चाहिए सर के स्वागत व अभिनंदन में. And since we are running short of time, we do not have adequate amount of time with us. I will try to be as fast and as quick as possible. So we are all set to inaugurate, to begin the first session for today. And I would now like to call upon stage our honorable moderator for the first session, who is none other than Dr. R.K. Modi sir from Purnia. And let us have a huge round of applause in order to welcome him on the stage. I would very humbly request you, sir, to kindly have your respective place on the stage. So he is the moderator for the first session. I would now like to call upon stage the chairpersons for the first session. So I would now like to invite on stage Dr. Umesh Khan sir from Jamshedpur, who has come over here in order to chair this particular session. Let's have a huge round of applause for him as well. एक बार शानदार तालियां आनी चाहिए. अब हमारे बीच हमारे प्रथम सेशन के चेयरपर्सन के स्वरूप में डॉक्टर उमेश खान जी अब हमारे बीच आ रहे हैं. इनके साथ साथ मैं आप लोगों के बीच बुलाना चाहूँगी डॉक्टर प्रभाकर ठाकुर जी बेगूसराय. एक बार शानदार तालियां आनी चाहिए डॉक्टर प्रभाकर ठाकुर सर के नाम. I would also like to call upon stage Dr. Mrityunjay Kumar from Bugusarai. एक बार शानदार तालियां इनके नाम पे भी. और इसी के साथ साथ अब मैं मंच पे आमंत्रित करना चाहूंगी चेयरपर्सन के स्वरूप में डॉक्टर दीपक फ्रॉम बेगूसराय. एक बार शानदार तालियां डॉक्टर दीपक के भी नाम. और इस प्रथम सेशन के लिए, इस प्रथम सत्र के लिए हमारे जो प्रथम वक्ता हैं वो हैं डॉक्टर राहुल कुमार सिंह फ्रॉम बेगूसराय. एक बार शानदार तालियां उनके स्वागत व अभिनंदन में. और अब मैं हमारे चेयरपर्सन्स से अनुरोध करूंगी कि वो हमारे प्रथम वक्ता को हम सभी के समक्ष उनका परिचय हम सभी के समक्ष रखें. और इसी के साथ मैं आप सभी को पुनः बहुत बहुत धन्यवाद कहना चाहूँगी और बहुत सारी शुभकामनाएं हम सभी लोगों की ओर से.
Thank you. On behalf of CCDSI, Bihar and Jharkhand 2023, I welcome all delegates and faculty and all senior members on the first scientific CME program. My first speaker will be Dr. Rahul Kumar Singh from Bugusarai. Dr. Rahul Kumar Singh, he's going to speak on type 1.5 diabetes mellitus. We all know that diabetes is divided into different groups. There was a bit confusion whether this type of diabetes, also known as LADA, latent autoimmune disease of adult, whether it is a part of type 1 or it's a part of type 2. Due to certain characteristic, we think that it was from part 1, like GAD positive, and due to certain characteristics, it was considered to be a part of 2, as the age of onset, usually more than 30 years of age. So let us hear with our Dr. Rahul, what is it? Dr. Rahul, please.
Thank you, sir.
यहाँ से आ जाइए, यहाँ से आपको करना है, नहीं तो आपको करना होगा। हाँ, उनका स्लाइड लगी है, डॉक्टर राहुल कुमार सिंह टॉप, बस इसको बड़ा कर।
Good morning to all of you. I feel privileged to be part of this conference, and I am thankful to our chairperson, Dr. P.K. Singh sir, Chairman Scientific Committee, Dr. Ajit Kumar Sinha sir, and my friend, young bright cardiologist, Dr. Sumit Kumar Burma, who have given me the opportunity to present over this important and burning topic, that is type 1 diabetes, type 1.5 diabetes mellitus. First of all, I initiate with a clinical history to make it more interesting. A patient of almost 40-year age came to my clinic for his symptom of hyperglycemia. When I evaluated, I found his blood sugar was around 300. His blood pressure was almost okay. His TSH was little bit raised, suggestive of hypothyroidism. I started diet control, lifestyle modification, and some oral hypoglycemic agent like glimepiride, glipizide, etc. Again, he came to my clinic, and I noticed that his sugar was now well controlled with these measures like diet and oral hypoglycemic agents. He was okay, and he frequently came to my clinic almost 1.5 years on a regular visit, and all symptoms as well as his laboratory measures are okay. After almost 1.5 to 2 years, when I do all these things, he was okay. But later on, I noticed that in spite of my oral hypoglycemic agent, diet and lifestyle modification, his blood sugar elevated like 300, 400, 250. I have tried another oral hypoglycemic agent as an add-on therapy, but in spite of that, sugar control is not adequate. This is the clinching point. What I want to stress, that a person age 35 to 50 year initially well controlled with diet and lifestyle modification with oral hypoglycemic agent, later on come to your clinic with raised blood sugar. You cannot control with all these things. Then what is this? Is this the type 1 diabetes which present later on? Because you already know that type 1 diabetes means absolute insulin deficiency. There is autoimmune process, there is destruction of beta cell, no insulin, only remedy is insulin therapy, no endogenous insulin. And in type 2 diabetes, insulin is okay, but the problem is insulin resistance. But here what is happening? Initially, patient was well controlled with drug and lifestyle modification. Later on, no drug work. The only thing you have to start insulin. Then what is this? I can say that this is a type 1 diabetes which presents in second part of life. So later onset type 1 diabetes initially was misdiagnosed type 2 diabetes. That's why scientists named it type 1.5 diabetes. Between 1 and 2. Initially it was type 2, it appears it was type 2 diabetes because later age of onset. You already know that type 1 diabetes, early age of onset. Type 2 diabetes, later age of onset. Type 2 diabetes, diet, lifestyle and drug are okay. Occasionally require insulin, later on. But this type 1.5 diabetes, that after 1 to 2 years, you cannot control with drug, oral hypoglycemic agent and diet lifestyle modification. You have to start insulin. So the scientist named it, as I told, LADA. Latent late onset. Latent means late onset. Late onset autoimmune diabetes of adult. When I was in CMC, they are told Dr. Nihal Thomas was my professor. Slowly evolving immune-mediated diabetic mellitus. They frequently used this term. Slowly evolving immune-mediated diabetic mellitus. So, there is an autoimmunity. Therefore, we have to confirm by testing of autoantibody. Now just come to slide. आप लोग बोर फील मत करिए, बस 10 स्लाइड है बात, 1 मिनट लगेगा। आप लोग को लग रहा होगा कि ये भाषण इतना दे दिया है, अभी स्लाइड भी आएगा, पता नहीं क्या करेगा, बस 10 मात्र only 10 स्लाइड। I have just introduced, I think all of you are aware that what is this? What is this type 1.5 diabetes? Means between type 1 and type 2, phenotypically, बाहर से physical appearance से it looks like type 1 diabetes because patient is lean and thin, not obese. No sign of insulin resistance. You already know the sign of insulin resistance like obesity, like triglyceride raised, like raised BMI. But in case of LADA, by BMI is usually less than 25 kg per meter square. So young and thin child, young and thin person. initially well controlled with drug, but later on require insulin. So just come to my slide. This is, as I already told you, type of diabetes occurring in adult with slowly progressive beta loss. It means there is immune-mediated destruction, so autoantibody are present, but they act slowly. So initially, patient secretes insulin. So you can control with oral hypoglycemic agent and lifestyle modification because there was some endogenous insulin. Gradually, destruction goes on. Insulin decreases, endogenous insulin decreases. Destruction goes on. So beta cells destroyed. The lot of patient has feature of both type 1 and type 2, I already told you. But they are phenotypically, this is important, they are phenotypically closer to type 1 diabetes, as I told you, that these patients are not obese. In action, a European multi-center study, 90% of patients were positive for GAD antibody. You already know there are 4 types of antibody which destroys the beta cells. In case of diabetes, most common is GAD. So 90% patients were positive for GAD antibody, and less frequent were another IC antibody, IA antibody, zinc transporter antibody, and tetraspinin 7 antibody. These all are the name of antibody which we test in our lab. Now how you diagnose it? I have already told you, but one diagnostic criteria proposed by IDS Society, Immunology of Diabetes Society, that a patient is older than 30-year-old, positive for antibody. 30-40 साल का एक आदमी आया, शुरुआती दौर में डाइट और दवा से उसका शुगर अच्छे कंट्रोल में था, बाद में वह काम नहीं कर रहा है, हम कोई भी ड्रग दिए जा रहे हैं, उसका शुगर बढ़ते जा रहा है। हमने सोचा ये कहीं लाडा तो नहीं, कहीं ये वो तो नहीं, ये मेरे माइंड में आया और फिर हमने उसका टेस्ट करवाया, एंटीबॉडी टेस्ट। एंटीबॉडी आपने अभी देखा कि 90% से ज्यादा केसेस में एंटीबॉडी मिलते हैं। सो एंटीबॉडी आर देयर। दिस इज ऑटो इम्यून प्रोसेस। मुझे अपनों ने ही लूटा, गैरों में कहां दम था। So this is just like autoimmune process, your own cell destroys your own body. So positive or at least one autoantibody, at least one autoantibody तो मिलता ही है। आप सब जानते हैं there are 4 kind of antibody in diabetes, type 1 diabetes. And third important thing, do not require insulin during early phase. As I told you, early phase, drug and oral hypoglycemic agent was sufficient to control sugar. No need of insulin. Later on, after passes 1 to 2 years, these drugs are not working and you have to add insulin. Now clinical feature, age of onset, I already told you, usually 30 to 50 years. That's why we confused that it is type 2 diabetes. Because later age of onset. Subclinical symptom of hyperglycemia. Subclinical means usually these patients do not present as diabetic ketoacidosis or HONG, hyperosmolar coma. These patients usually present with sugar level of 250, 300. No very acute symptom, subclinical symptom. So you confuse that it is type 2 diabetes. These are the confusing points. Insulin requirement greater than 6 months after diagnosis. So early drug and lifestyle is okay. Later on we require insulin. इंसुलिन रेसिस्टेंस का टेस्ट होता है, होमा एयर टेस्ट आप सब लोग जानते हैं। इंसुलिन रेसिस्टेंस समटाइम्स इन दीज पेशेंट्स इंसुलिन रेसिस्टेंस लिटिल बिट इंक्रीज्ड और समटाइम्स नॉट इंक्रीज्ड। When we test insulin resistance in these patients, sometimes it is increased, sometimes okay, normal. BMI, I already told you, usually rarely greater than 25 kg per meter. It means these patients are usually not overweight. So this is against the type 2 diabetes. It resembles type 1 diabetes. The patient is lean and thin, not obese. We already know usually type 2 diabetic patients are obese. But these patients are not obese. And absence of feature of metabolic syndrome, I already told you, like hyperglycemia, hypertension, hypertriglyceridemia, increased BMI, increased waist hip ratio. These are the feature of metabolic syndrome. Here absent. So resembles type 1 diabetes. So I told you already that this is phenotypically closer to type 1 diabetes. As we can say that this is a type 1 diabetes which is later onset. It means after 30 to 40 years. So later onset diabetes, type 1 diabetes is LADA or slowly evolving immune mediated diabetes or type 1.5 diabetes. I know some of you were surprised with this name. But I have already explained that why this name is given. Why type 1.5? Because it is between type 1 and type 2. Share both features. Biochemical feature. Islet cell autoantibody are present in high titer. So to confirm the diagnosis of this LADA, we have to test the autoantibody. First we test C peptide level. You already know that C peptide level is the marker of endogenous insulin production. Type 1 diabetes, C peptide level no, absent, very less. Type 2 diabetes, it is okay, normal range. In LADA, yes, it is less than type 2 diabetic, but more than type 1. So little bit C peptide is present. And when C peptide is present, we go for autoantibody test. So C peptide level at diagnosis are decreased, but still detectable. In type 1 diabetes, no C peptide. In type 2 diabetes, okay or elevated C peptide. Here, between 1 and 2. So C peptide level little bit decreased, or autoantibody present. Later age of onset, it is a LADA. Pathophysiological feature. MSC association, sometimes you already know major histocompatibility complex association. Sometimes it is high, sometimes it is mild. Family history of diabetes could be present, could not be present. Type 2 diabetes, family history usually present. Type 1 diabetes, usually no family history. This 1.5 diabetes could be. Yes, again in between. Could be present, could be absent. Family history of autoimmune disease. Yes, it is present. You already know that there are many autoimmune disease like SLE, like thyroid problem, like vitiligo. So these are the autoimmune disease. Autoimmune disease present. Chances are more. So if you diagnose LADA, we have to search for another autoantibody. We have to search for another autoimmune disease that it might present. There are chances that present. It resembles type 1 diabetes. Because type 1 diabetes, yes, family history present. LADA, family history of autoimmunity present. Drawbacks. As I told you, misdiagnosis. We usually market type 2 diabetes or late diagnosis. We usually market type 2 diabetes. And second important drawback, every patient of LADA ultimately require insulin like type 1 diabetes, basal bolus regimen. We already know this. No drug will work later on. Initially, drug and lifestyle is okay, but later on we have to give insulin. No chance. No anything will work. Treatment only aim is to protect beta cell because there is immune-mediated destruction. Faster progression to insulin requirement. So sulfonylurea group of drug not recommended. Like glimepiride, glipizide, gliclazide. Remember, do not prescribe it if you suspect LADA. So 40 साल का आदमी constant high sugar, glimepiride 3 milligram सुबह शाम, glimepiride 4 milligram सुबह शाम, not controlled. Think about LADA and stop prescribing sulfonylurea. क्योंकि अगर आप ये देते रहिएगा तो इसका और तेजी से बीटा सेल डिस्ट्रॉयड होगा, ऐसा देखा गया है. So early need of insulin will arise. So avoid sulfonylurea. Drug में हम early initiation of insulin therapy in LADA improves metabolic control while protecting beta cell function. So अगर हम diagnose किए LADA तो हम मरीज को उसी समय से sensitize करना शुरू कर दें कि आप इंसुलिन पर आ जाइए. Even though some endogenous insulin were there, लेकिन हम लोग सलाह देंगे कि आप इंसुलिन थेरेपी पर आइए. Just come to insulin therapy because it will control your metabolic symptoms. It will protect your beta cells. Insulin sensitizers, metformin and pioglitazone group of drugs seems beneficial. थोड़ी लाभ हो सकती है, ऐसा देखा गया है. But not very promising. Only insulin is the remedy. Once we diagnose this insulin, we must think about the insulin and we have to sensitize patient regarding use of insulin. Okay. Now summary. 10% of diagnosed patient type 2 diabetes are having LADA. There is data 10 to 20% patient we mark it type 2 diabetes, but later on it proves to be LADA. LADA is a form of diabetes occurring in adults with slowly progressive beta cell loss. Why loss? Because there is autoantibody. Phenotypically closer to type 1 diabetes. डायग्नोसिस के लिए बीटा सेल एंटीबॉडी हम लैब से टेस्ट करवाएंगे. आप सब जानते हैं 4 तरह का एंटीबॉडी यूजुअली होता है, जिसमें गैट सबसे कॉमन होता है. इंसुलिन इज द ओनली प्रॉमिसिंग ट्रीटमेंट. ड्रग्स नॉट वर्किंग. मैसेज I already explained you. Suspect LADA in any patient of diabetes whose plasma sugar are well controlled, initially with diet modification and drugs, oral hypoglycemic agent, but later on not controlled with that, and we have to start insulin, then we think that it could be LADA.
Thank you, Dr. Rahul.
Thank you, sir,
for your masterly presentation. Mr. Moderator, please, if you can have any question.
Congratulations, Dr. Rahul. You have spoken well about this 1.5 or 1.5 diabetes. Truly speaking, it is type 1 diabetes which has got a slowly evolving form. Actually, in temporal model of type 1, we have a diabetes in which there is intrinsic factor, that is pre-existing factor, followed by some trigger. So first there is genetic susceptibility, then some environmental factor, might be a virus, a cold weather, that can trigger the autoimmune response. And due to autoimmunity, there is destruction of the beta cells. And after destruction, there is declining in the insulin secretion and eventually diabetes results. But this entire process is very fast. So almost all type 1 diabetes occurs before age of 15, 20, 16 or 18. The process is very fast, but we have slowly evolving forms of type 1, and LADA is an example of slowly evolving form of type 1 diabetes in adults. And in the same way, in young, we have LADI, that is latent autoimmune diabetes in young. The process is same. The three catch points are, you have well spoken that if a patient which seems to be type 2 suddenly loses his response to oral drug, so you think you have taken 1, 2, 3 drugs, multiple drugs, not responding. So you may think that he may have type 1 diabetes. You can go for antibody test, number one. Number two, if there is associated other autoimmune disorders like Hashimoto thyroiditis, celiac disease or vitiligo, so in that case also you think there may be type 1 diabetes as well. So there the management becomes difficult because you have to deal with two types of autoimmune disorder at a time. And thirdly, very unfortunately, in our etiological classification of diabetes, we classify diabetes type 1, type 2, other forms of diabetes and gestational diabetes. But in whole the spectrum, there is no place for 1.5 diabetes or LADA. But the classification given by WHO in 2019, they have described very nicely hybrid form of diabetes, and it is nicely written there. There are two varieties of hybrid form. One is LADA and other is type ketosis prone type 2 diabetes. Altogether, it was a nice deliberation. May I invite the second speaker?
Thank you, sir.
We can have one or two questions, only one or two questions, because we are already late. Any comment or any question? Anyhow, Dr. Rahul, is there any paper suggesting the use of biologics, because it has got an autoimmune basis? Any role of biologics in the treatment, long-term treatment of this disease? Biologics.
Biological modifiers. Yeah. Sir, there is no any recommendation right now. No any textbook suggests that any use of these immunosuppressant drugs like biological DMARDs, जिसको हम लोग बोलते हैं. So use in type 1.5 diabetes, there is no any recommendation up till now from any textbook, any standard guidelines. No recommendation.
Thank you.
Hello. There have been recent trials with alum recombinant GAD given subcutaneously in type 1 diabetes. The initial results are very promising. We have to wait and see. So that is the first biologic that has been tried.
Thank you, Dr. Bhimani.
Thank you, sir, for this important information.
Thank you, Dr. Rahul. Thank you.
Thank you, sir.
Oh, you want to have question? Thank you.
Good morning. I would like to welcome Dr. R.R. Verma sir for next talk, Carbohydrate Facts for Diabetes. Dr. Verma is MD Medicine and he was ex-CMO, Government of Bihar. He is a famous physician and diabetologist at Gaya. Sir has obtained training from Mumbai, Delhi, Chennai, various big hospitals. So I would like to welcome Dr. R. Verma sir.
Respected Chairman and my senior colleagues and juniors, I shall be talking about a very common topic for all the diabetologists. Every patient asks the question, क्या खाना है? हर एक 100% of patient has this question कि हम क्या खाएं, क्या नहीं खाएं. उसी से संबंधित है तो बहुत कुछ. डायबिटिक डाइट एज ए होल इज ए बिग चैप्टर. कुछ कार्बोहाइड्रेट के बारे में हम आज 15 मिनट में बताना चाहेंगे। सबसे पहले डाइट के बारे में हम लोग कैलोरी, प्रोटीन, कार्बोहाइड्रेट और फैट से ही लेते हैं, यही 3 चीज है। तो इसमें कौन चीज कितना लें, कार्बोहाइड्रेट कितना लें, प्रोटीन कितना लें, फैट कितना लें, ये क्वेश्चन हमेशा आता है। ये कैलकुलेट करना बहुत आसान है, हम लोग कोई भी कैलकुलेट कर सकते हैं। सबसे पहले हमको प्रोटीन कैलकुलेट करना है, कार्बोहाइड्रेट पहले नहीं, पहले प्रोटीन। पहले प्रोटीन अगर कैलकुलेट कर लेंगे तो काम आसान हो जाएगा। अक्सर यह बात कहा जाता है कि प्रोटीन खूब खाना चाहिए। कल अजय सर का जो प्रेजेंटेशन देखे होंगे उसमें उन्होंने एक स्लाइड में कहा था कि बहुत ज्यादा प्रोटीन कभी कभी हार्मफुल हो सकता है। तो प्रोटीन रिकमेंडेशन कितना है? स्टैंडर्ड रिकमेंडेशन है 0.8 kg पर बॉडी वेट, 0.8 ग्राम पर kg बॉडी वेट। मान लीजिए 1 ग्राम भी अगर आप देते हैं तो 60 kg के आदमी में अगर हम कैलकुलेट करें तो 60 ग्राम आपको प्रोटीन देना है, और 60 ग्राम प्रोटीन ही देना है। बहुत ज्यादा प्रोटीन देने से एक चीज यहाँ बता दें, डायबिटिक के लिए हाई प्रोटीन डाइट इट इज नॉट सुटेबल फॉर एनी डायबिटिक। सिर्फ जो रिक्वायरमेंट है उतना ही लेना है, उससे ज्यादा लेने से जैसे बाजार की बात हो या फिर बहुत तरह का लिटरेचर की बात हो, कमेंट की बात हो कि प्रोटीन खूब खाना चाहिए, तो वो चीज यहाँ लागू नहीं होता है। डायबिटिक में ये चीज लागू नहीं होता है। डायबिटिक को मोटा मोटी 1 ग्राम पर kg बॉडी वेट ही प्रोटीन खाना है, और अगर उसके डाइट में लगभग इतना सफिशिएंट प्रोटीन है 0.8 ग्राम टू 1 kg बॉडी वेट अगर वो खा रहा है तो उसको प्रोटीन सप्लीमेंट की जरूरत नहीं है। प्रोटीन सप्लीमेंट ये सब की जरूरत तो पड़ती ही है, जैसे प्रोटीन एनर्जी, माल न्यूट्रिशन ये सब होता है, तब प्रोटीन ज्यादा प्रोटीन की जरूरत पड़ती है। डायबिटिक को ज्यादा प्रोटीन की जरूरत नहीं है। तो हम लोग जोड़ लें, अगर 1 ग्राम के हिसाब से 60 ग्राम, 60 kg आदमी में 60 ग्राम से 6 चौके 24, 240 कैलोरी मिलेगा। अब आइए फैट पर, कि फैट कितना खाना है। फैट लगभग 1/4 ऑफ द टोटल कैलोरी, यानी अगर 2000 कैलोरी है तो 500 कुछ बढ़ा भी दें तो लगभग 600 कैलोरी फैट से लेंगे। तो 6 2 8 840 कैलोरी आपको फैट और प्रोटीन से मिल गया। अब सिर्फ एक चीज बचा, कार्बोहाइड्रेट। बाकी आपको कार्बोहाइड्रेट से लेना है। इसलिए कहा जाता है कभी कि 40% कार्बोहाइड्रेट लीजिए, 45% लीजिए, 50, 60, 65 जो भी लेना हो, बस इसी कैलकुलेशन पर आप कैलकुलेट कर लीजिए कि अगर 840 कैलोरी अगर आपको प्रोटीन और फैट से मिल गया तो कार्बोहाइड्रेट बाकी आपको अब कार्बोहाइड्रेट ही लेना है, क्योंकि और चौथा तो कुछ है नहीं। तो हो जाएगा 1160। तो 1150 कैलोरी आपको कार्बोहाइड्रेट से ही लेना है। इसलिए कार्बोहाइड्रेट कम करने का डायबिटिक डाइट में कोई चांस नहीं है। एक्चुअली एनी स्टैंडर्ड डाइट, वेदर यू हैव डायबिटीज और नॉट, दैट इज अ डायबिटिक डाइट। कोई भी जो लाइफस्टाइल मॉडिफिकेशन में हम लोग बोलते हैं, जो स्टैंडर्ड डाइट जो होना चाहिए वही डायबिटिक डाइट है। डायबिटिक डाइट नाम का कोई चीज दुनिया में नहीं है, ये हम लोग के द्वारा आविष्कार किया गया है। डायबिटिक डाइट, डायबिटिक डाइट नाम का कोई चीज नहीं होता है। और बाकी बैलेंस करने के लिए तो वाटर, विटामिन, मिनरल, फाइबर, माइक्रोन्यूट्रिएंट्स ये सब रहता ही है। अब हम लोग कहते हैं जैसे भात के बारे में कहा जाता है, बाकी बात भी बात करेंगे तुरंत 2 मिनट के बाद। हम लोग भात के साथ दाल खाते क्यों हैं? तो उसका आंसर, एक आंसर है लिमिटिंग एमिनो एसिड। चावल में लाइसिन बहुत कम होता है, नहीं के बराबर। वो दाल में रहता है, और दाल का भी अपना लिमिटिंग एमिनो एसिड है मेथायोनिन, जो चावल में रहता है। तो इसीलिए अगर आप चावल और दाल मिला करके खाते हैं तब आपका फूड कंप्लीट होता है। और चावल खाना है या नहीं खाना है वो हम लोग 1 मिनट में बात कर लेंगे। दाल खाना है ये तो सभी लोग जानते हैं, दाल में प्रोटीन होता है ये भी सभी लोग जानते हैं, लेकिन दाल में कार्बोहाइड्रेट ज्यादा होता है, प्रोटीन कम होता है। भले प्रोटीन 20% हो लेकिन कार्बोहाइड्रेट भी 50% होता है। तो सबसे बड़ा प्रॉब्लम शुगर से आता है डायबिटीज में। हम लोग डायबिटीज के संदर्भ में कार्बोहाइड्रेट का बात कर रहे हैं। तो सबसे बड़ा प्रॉब्लम शुगर का आता है। ब्लड शुगर, हम लोग डायबिटीज जानने के लिए ब्लड शुगर नापते हैं। डॉक्टरों से भी मेरी ये शिकायत है कि हम लोग ब्लड शुगर बोलते क्यों हैं? शुगर का मतलब होता है सुक्रोज, शुगर का मतलब ग्लूकोज नहीं होता है। और इसका महत्व इसलिए है कि अगर हम ब्लड शुगर बोलते हैं, इससे ये पता चलता है कि ये चीनी की बीमारी है। क्या ये चीनी की बीमारी है? तो आप लोग खुद बता सकते हैं। ये सुक्रोज कभी आज तक वर्ल्ड के किसी भी आदमी के ब्लड में सुक्रोज या चीनी नहीं पाया गया है। ये सुक्रोज की बीमारी नहीं है, यानी वो जो चीनी हम लोग शब्द का इस्तेमाल करते हैं, ये चीनी की बीमारी है ही नहीं, ग्लूकोज की बीमारी है। और ग्लूकोज और सुक्रोज के बीच में सभी को मालूम है क्या फर्क है। सुक्रोज इज ए कॉम्बिनेशन ऑफ ग्लूकोज एंड फ्रक्टोज। दूसरा डिफरेंस और भी डिफरेंस है, ग्लूकोज मोनोसैकेराइड है, सुक्रोज तो डाइसैकेराइड है। ग्लूकोज का ग्लाइसेमिक इंडेक्स 100 है, लेकिन चीनी या सुक्रोज का ग्लाइसेमिक इंडेक्स 100 नहीं है। क्यों नहीं है? इसलिए कि वो ग्लूकोज और फ्रक्टोज से मिलकर के बना है। और आपको आश्चर्य होगा ये जान करके कि फ्रक्टोज का ग्लाइसेमिक इंडेक्स कितना है। ग्लूकोज का तो 100 है, वही स्टैंडर्ड है, लेकिन फ्रक्टोज का 15 से 20 है, 40, 50, 60, 70 भी नहीं है। ये 20 से कम है फ्रक्टोज का। तो इसीलिए चीनी का ग्लाइसेमिक इंडेक्स 65 के आसपास है, 100 नहीं है। आप लोगों को यहीं पर बता दें, रोटी का भी ग्लाइसेमिक इंडेक्स 65 ही है, चीनी का भी 65 ही है। तो ब्लड शुगर बोलने से चीनी की बीमारी हो जाता है। उसका रिपरकशन ये है कि पब्लिक उसको चीनी की बीमारी समझ लेती है और वो ये मान के चलती है कि जो चीनी हम खा रहे हैं वही ब्लड में चला जाता है। वैसे तो हम कुछ भी खाते हैं तो वो ग्लूकोज बनकर के ब्लड में चला जाता है, लेकिन चीनी बोलने से ये होता है, वो ये सोचता है कि चीनी ही खाने से चीनी बढ़ जाता है, और लोग चीनी को 100% बंद करने का कोशिश करते हैं। तो एक गलत बात पब्लिक में चला जाता है, उसके मन में ये बैठ जाता है कि चीनी बिल्कुल नहीं खाना है। पब्लिक सभी तरह का, चाहे वो पढ़ा लिखा हो या अनपढ़ हो, सब बात बराबर है। चीनी नहीं खाना चाहिए ये बात सभी के मन में बैठ जाता है। और चीनी खाएंगे तो क्या होगा? खून में चीनी बढ़ जाएगा। वो चीनी जो नॉन एग्जिस्टेंट है, ब्लड सुक्रोज इज ए नॉन एग्जिस्टेंट मटेरियल। तो ग्लाइसेमिक इंडेक्स तो हर एक कार्बोहाइड्रेट का प्रॉपर्टी है कि फैट या प्रोटीन का ग्लाइसेमिक इंडेक्स लगभग 0 होता है। उसका क्या महत्व है वो भी हम लोग बात कर लेंगे। ये कार्बोहाइड्रेट का मामला है, ग्लाइसेमिक इंडेक्स जो कि ग्लूकोज का स्टैंडर्ड माना जाता है और उसका 100 स्टैंडर्ड मान करके और उसी से कंपेयर किया जाता है कि दूसरे कार्बोहाइड्रेट का ग्लाइसेमिक इंडेक्स कितना है। हाई, मीडियम और लो है। हाई मैंने 70 प्लस, मीडियम मैंने 55 टू 70 और लो मैंने बिलो 55। तो कुछ ग्लाइसेमिक इंडेक्स जान लेने से अच्छा रहता है। डाइटरी एडवाइस अगर देना है, राइस का 70 के आसपास है। 70 से 2-3 ज्यादा भी हो सकता है, 2-3 कम भी हो सकता है, अलग अलग राइस के वैरायटी पर। व्हीट जो रोटी की बात की है वो लगभग एग्जैक्ट नहीं है, लगभग 65 के आसपास है। अब फ्रूट्स, ये भी एक इम्पॉर्टेंट मैटर है क्योंकि ऑलमोस्ट ऑल फ्रूट्स हैव लोअर ग्लाइसेमिक इंडेक्स, लो यानी बिलो 55। ऑल फ्रूट्स एक्सेप्ट वन, वाटरमेलन। सिर्फ आपको किताब में खोजिएगा तो सिर्फ वाटरमेलन का जो तरबूज है सिर्फ उसी का ज्यादा मिलेगा। बाकी सभी फ्रूट, ऑल फ्रूट्स, चाहे उसका नाम अंगूर हो, उसका नाम आम हो, उसका नाम सेब हो, जो भी नाम है, ऑल फ्रूट्स हैव लो ग्लाइसेमिक इंडेक्स। उसका दो मेन कारण है। एक तो फ्रूट का नाम फ्रक्टोज से पड़ा है और फ्रक्टोज का ग्लाइसेमिक इंडेक्स 20 से कम होता है। और दूसरा सभी फ्रूट्स में फाइबर होता है। जहां पर फाइबर और फ्रक्टोज रहेगा उसका ग्लाइसेमिक इंडेक्स कम होने का गारंटी है। वैसे फैट और प्रोटीन के बारे में भी एक मिनट बोलना जरूरी है। प्रोटीन और फैट का ग्लाइसेमिक इंडेक्स लगभग 0 है। किसी भी खाना में अगर आप उसमें प्रोटीन मिला दीजिएगा या फैट मिला दीजिएगा या फाइबर मिला दीजिएगा या तीनों में से कोई एक या दो या तीनों मिला दीजिएगा, उस खाना का ग्लाइसेमिक इंडेक्स कम हो जाएगा, यानी लोअर कैटेगरी में चला जाएगा। मीडियम से भी। इसीलिए एक्चुअली आजकल ग्लाइसेमिक इंडेक्स का महत्व खत्म होते जा रहा है। उसका कारण है कि अकेला अकेली कोई कुछ नहीं खाता है। कोई आदमी अकेले चीनी नहीं खाता है ना, कोई भी आदमी घी नहीं खाता है, कोई भी आदमी सब मिक्स फ्रूट, चाहे आप रोटी, सब्जी, चावल, दाल, फल जो कुछ भी खाते हैं, आप जब भी खाते हैं मिक्स्ड फूड खाते हैं, मिश्रित भोजन करते हैं। और जितना भी मिश्रित भोजन है उसमें कार्बोहाइड्रेट के साथ फाइबर रहता है, फैट रहता है, प्रोटीन रहता है। तो गारंटीड हर एक खाना जो आप खा रहे हैं, खास करके इंडियन फूड के बारे में हम बताना चाहेंगे। इंडियन foods all over India, in all the states of India, it is always a balanced food. और इंडियन फूड जितना भी है, जो भी मिश्रित भोजन है, हम लोग जो मिक्स्ड फूड खाते हैं, अकेले चावल कोई नहीं खाता है, अकेले दाल कोई नहीं खाता है, हर एक आदमी मिक्स्ड फूड खा रहा है। इसलिए ग्लाइसेमिक इंडेक्स का महत्व ही खत्म हो रहा है। अब ग्लाइसेमिक इंडेक्स का कोई ये सिर्फ एकेडमिक इंपॉर्टेंस है कि फलाने का ग्लाइसेमिक इंडेक्स इतना है। जब हम हमेशा मिश्रित फूड ही खा रहे हैं, मिक्स्ड फूड ही खा रहे हैं, तो ग्लाइसेमिक इंडेक्स जोड़ने की जरूरत ही नहीं, वो तो हमेशा 50 से कम रहेगा। प्रोटीन, फैट और फाइबर तो वही चीज हो गया कि मिला देंगे तो ये होता है। बढ़ा दीजिए। एबनॉर्मल फूड के बारे में अजय सर भी कल प्रोटीन फूड ही के बारे में बोल रहे थे। ये प्रोटीन से हाई प्रोटीन डाइट लेने से कैसे एक लेडी का डेथ हो गया। उसी से मिलता जुलता चीज ये है रैबिट स्टार्वेशन। रैबिट एक बहुत हाई क्वालिटी प्रोटीन है जिसमें कि कार्बोहाइड्रेट फैट इसकी सबकी मात्रा नहीं के बराबर है। अगर आप वेरी हाई प्रोटीन डाइट खाइएगा तो क्या हो सकता है, आप हेल्दी नहीं होइएगा बल्कि आपका डेथ भी हो सकता है। कैसे? सबसे पहले नोजिया होगा, उसके बाद स्टार्वेशन कीटोसिस होने लगेगा, डेबिलिटेशन होने लगेगा और बाद में अगर आप बहुत वेरी हाई प्रोटीन डाइट कंटिन्यू करते हैं तो कुछ भी बुरा हो सकता है। Thank you very much.
Wonderful, sir. It was a real, very practical, very informative talk, and very presented in a very simple manner. I really congratulate you, sir. A few things I just want to add in that nowadays the diet for a diabetic patient, it must be individualized because the content of a diet in the form of carbohydrate, protein and fat may vary according to the target we fix for a diabetic patient. Meaning thereby, sometimes we advise a diet which is ideally what you have spoken, that our diabetic diet should be predominantly carbohydrate followed by protein and lastly fat. That is there. But we have low carbohydrate type of meal, very low carbohydrate type of meal, in that the carbohydrate content is being reduced and it will give only 24 to 30% of the total calorie we are required. But when we reduce the calorie from carbohydrate, other calorie will be filled by protein. Now of course we have to increase the amount of protein we consume, and in keto diet we reduce carbohydrate and we take all calories from the fat. That is there. So there are many advantages and disadvantages of such type of diet, and nowadays in the recent Mediterranean diet is supposed to be a better diet for a diabetic patient. So congratulations, sir. Anything?
No, sir. Thank you.
Okay. Then we move. Thank you, sir. We move to the next topic. Yeah.
Question.
There is one question, na? There is one question, sir, please.
डॉक्टर आर वर्मा सर ने बहुत ही सरल भाषा और दिलचस्प तरीके से हिंदी में डायबिटीज के ऊपर जो व्याख्यान दिया, मैं उनका बहुत आभारी हूँ। मेरा एक प्रश्न है, अक्सर जब हम पार्टीज या भोज में जाते हैं, कोई हमको मिठाई ऑफर करता है तो मैं डर जाता हूँ कि मुझे डायबिटीज हो जाएगा। मैं पूछना चाहता हूँ, क्या सिर्फ मिठाई खाने से डायबिटीज होगा?
बहुत सिंपल है, हम लोग तो सब डॉक्टर हैं यहाँ। मिठाई है क्या? मिठाई इज ए मिक्सचर ऑफ कार्बोहाइड्रेट, प्रोटीन एंड फैट। क्या है? ये तीनों का मिक्सचर है। कार्बोहाइड्रेट है, मान लीजिए चीनी है, फैट तो है ही जो कि घी से बना हुआ है, और प्रोटीन भी है उसमें, मिल्क प्रोटीन है। तो मिठाई का ग्लाइसेमिक इंडेक्स तो कम होगा ही। हम लोगों को खाली ग्लाइसेमिक इंडेक्स बात करने से तो होगा नहीं, हम तो सिर्फ 15 मिनट बोले। ग्लाइसेमिक लोड भी तो कुछ होता है, अगर आप बहुत ज्यादा कैलोरी ले लीजिएगा तो वो भी तो प्रॉब्लम है। तो मिठाई का मतलब है कि ऐसा ना हो कि अननेसेसरी मेरा कैलोरी बहुत बढ़ जाए। मिठाई से आपका ब्लड शुगर नहीं बढ़ने वाला है, वो तो 50-60 के आसपास ही आपका ग्लाइसेमिक इंडेक्स रहेगा अगर टोटल का देखिए तो। दूसरी बात, अगर आधा मिनट का समय शुगर फ्री की बात होती है, शुगर फ्री मिठाई भी बाजार में आ गया है। किसी भी चीज का कैलोरी, कार्बोहाइड्रेट, फैट या प्रोटीन, किसी का भी कैलोरी उसके वजन से होता है, वजन से। जैसे मान लीजिए कि आप 25 ग्राम के मिठाई में 5 ग्राम चीनी मिला दीजिएगा, तो मैंने 25 ग्राम का मिठाई है, उसमें 5 ग्राम चीनी है, तो टोटल 25 ग्राम हो गया। तो 25 ग्राम का जो कैलोरी होगा वो हो जाएगा, सब मिला करके फैट, प्रोटीन और कार्बोहाइड्रेट। अब उसमें हम चीनी हटा करके शुगर फ्री मिला दिए, तो क्या होगा, उस मिठाई का वजन कितना हो जाएगा? 21 ग्राम भी नहीं होगा, 20 ग्राम रह जाएगा, 20.1 ग्राम हो जाएगा। शुगर फ्री का तो कोई वजन है नहीं। अगर हम चीनी 5 ग्राम चीनी हटा के उसमें 1 टैबलेट या 2 टैबलेट शुगर फ्री मिला देंगे, तो उसका वजन तो 20 ग्राम रह गया ना। अब हमको 20 ग्राम का कैलोरी नापना है ना, 25 ग्राम का कैलोरी नहीं नापना है। तो शुगर फ्री रहे या न रहे, सब बात बराबर है। वो सिर्फ एक गिमिक है। चाहिए शुगर फ्री के नाम से डायबिटिक लोग तुरंत प्रभावित हो जाते हैं, इसलिए शुगर फ्री और खाइए या चीनी वाला मिठाई खाइए, बात बराबर है। अगर 20 ग्राम का 20 ग्राम खाइएगा तो दोनों बात बराबर है।
जी सर, थैंक यू सर। डॉक्टर अजय कुमार सिन्हा, प्लीज सर।
My compliments to Verma ji. Wonderful talk, because this is what all of us we require. Not only public. In fact, all physicians who are practicing diabetes should know all about it. So this was a wonderful talk. Number one. Number two, few things about keto diet. In fact, the newsletter which we will release today has got a small topic on keto diet. And keto diet, the biggest problem with keto diet is that it is atherogenic. It is highly atherogenic. It has got highly atherogenic potential. One. Secondly, comment about the sugar substitutes. All of them are dangerous. They are dangerous because they can create a lot of cardiovascular insults. So these are the two comments I wanted to make. Thank you.
Firstly,
Thank you, sir. Agreed. Now, sir, can we move to the next speaker? So I invite Dr. N.C. Singhal. He is going to speak over diabetes and gut microbiota. Dr. Singhal, please.
Respected chairman sirs and members of the audience, I have chosen this topic of probiotics
Slide, please.
Yeah. नहीं, सेकंड स्लाइड पे जाइए। और हाँ, और अच्छा ठीक है, ठीक। So I have chosen this topic of probiotics because being a gastro myself, you see, we have been using probiotics in lot of gastrointestinal problems. But unfortunately, the role of probiotic in diabetes is a very less talked about subject in almost all the conferences, especially in the diabetic conferences. Now, what is a probiotic? Probiotic is nothing but a bacteria. Now, bacteria can be a harmful bacteria, it can be a helpful bacteria. So, probiotic is a helpful bacteria. It stays in the system but does not cause any harmful effects. And what is a prebiotic? Now, prebiotics is nothing but substances that help in the for functioning of probiotics, and these are generally non-living substances. Like lot of mention has been done about the food yesterday, today, fiber foods, vegetables. All these are prebiotics and they help in the functioning of the probiotics. Now, regarding the bacteria in the gut and diabetes, we don't know much about it because nobody talks about it. So, actually, what is all these constitute the genes, the environment, the behaviors of the bacteria. These all constitute the microbiome of the gut, and the interrelation between organisms in the gut and factors associated with diabetes is very, very complex and nobody likes to talk about it. Now, coming to the average human is a composite of species, a superorganism. There are about 37.2 trillion human cells, approximately 20,000 active genes, but that's not all. We function as scaffolding for numerous other organisms in that symbiotic relationship. The cells in every person are outnumbered by bacterial cells in the gut alone by 100:1. The genes in every person are outnumbered by 1,000:1. The variety of organisms in men are more diverse than any other naturally occurring colonization. And the bacteria in the gut collectively weigh almost about 6 pounds. Can you imagine 6 pounds of bacteria are present in your gut? And the bacteria in the gut alone have a myriad of positive, neutral, and in some cases negative effects and are collectively referred to as the gut microbiome. Now see the distribution of the bacteria in the human system. You see, starting from the oral cavity, skin, duodenum, colon, stomach, all these places, jejunum, ileum, and all these, you see, the distribution is such that they all outnumber 10 to the power of 10 and above. See the distribution of the various bacteria throughout the human system. Now, this is the gut in cross-section. The cells in the intestine are exposed to bacteria and food breakdown products, all these bacteria. In addition, the gut is a major place where non-self antigens are recognized by interaction with the immune system, which is integrated with the intestinal cells. These probiotics, they help in the immune system. Now, see, these are the thousands of articles which have been written in the literature. You have a lot of ongoing research papers also. See, in the celiac disease, in colon-carcinoma, liver disease, pancreatic disease, all these are the various papers and researches going on as far as the probiotics are concerned. And there, second last, you see the diabetics. Almost more than 2,000 research papers are there where guts and probiotics are concerned. Now, why is diabetes linked with microbiota? See, the first point of interest is that researchers have observed differences in gut microbiota composition between those with diabetes and healthy control. Meaning that in the diabetics, there is a different microbiota, and in the non-diabetic also, they differ with each other. Now, the bacteria that differ between the groups appear to be microbes that primarily influence inflammation and energy homeostasis. And there is no single feature of gut microbiota composition that signals diabetes. It is clear that generally those with type 2 diabetes show a reduction of butyrate-producing species, and increase and thereby increase in the opportunistic pathogens. Now regarding the function, the gut microbe functions also different with those with type 2 diabetes. Some observed differences include increased membrane transport of sugars or branched amino acids, change activity in genotic and carbohydrate metabolism, reduced butyrate synthesis, and decreased cofactor and vitamin metabolism. These are all the negative factors. Now, evidence suggests that these differences in gut microbe composition and function are not relevant to the course of the disease. Gut bacterial composition associated with response to dietary intervention, as shown in recent paper by Dow and teams of Karen and other people, that in obese subjects, they have equal potential for weight loss induced improvement of metabolic disorders when they adopt a calorie restricted diet. And the researchers found that the presence of L-theramine mucinophilia, which is a probiotic, is a more beneficial response to the dietary intervention, and those with more A-mucinophilia behaved well in the gut, responded better to the dietary restriction in terms of reduced visceral fat. Mechanism of action, we have low-grade systemic inflammation, maybe the driver of metabolic changes that are linked to insulin resistance and obesity. The trigger of this inflammation is not known, although we are beginning to understand more about the complex cascade of effects that leads to inflammatory state. The gut microbiota and certain microbial metabolites seem to be intimately involved in these effects. Now, what is the role of metabolites? In addition to bacteria themselves, bacterial metabolites and components play a role in controlling the host immune system and glucose metabolism. Metabolites appear to influence the intestinal cells involved in endocrine and gut barrier functions. This is a gut microbe and metabolic disorder. The gut bacterial community plays an important role in the regulation of multiple aspects of metabolic disorders. The bacterial metabolites involved in these interactions are very diverse. They include byproducts of bacterial metabolism such as short-chain fatty acids, complex macromolecules, and others. And abundance and availability of these metabolites are dependent on the microbial composition and therefore subject to modulation by diet and others. Now, what is the effect on glucose? You see, the glucagon secreted by the pancreas, the stress hormones by kidney, epinephrine, they all increase the effect on glucose, whereas insulin from pancreas, amylin, gut hormones, incretins, GLP-1, they all have negative effect on the glucose. Rather, they reduce the glucose, Now, what happens in a leaky gut? Leaky gut means when the gut barrier deteriorates, the endotoxins from various bacteria as well as other products may leak into the blood. See, here you see on the left you have a normal intestinal wall. On the right you have another intestinal wall in which the green layer is the mucus layer which is reduced, and in this the gut there is leakage of in the gut, and microbiota enlargement is a feature of metabolic disease, particularly insulin resistance associated with glycemia. Here again you see in this diagram on the leaky gut, on the left side is the normal gut, on the right side you see the gut mucus layer is depleted and bombarded by the bacteria. See what happens is when in the diet, in a diabetic, when fat and sugar they are taken, they cause release of then LPS is released, or translocation of bacteria occurs. The adenocytes release fatty acid, and others are so on, so on. There is all dysbiosis over there, and endotoxins go inside the blood. This is what happens in T1 diabetes and T2 diabetes. All these pass into the system and cause the problems. This is another diagram in showing that various what are the helpful factors, what are the non-helpful factors. The short chain fatty acids mediate glucose homeostasis, then other bile acids, LPS induces low-grade inflammation and insulin resistance by binding to TLR4. What are the emerging concepts? Besides the classical molecules such as short-chain fatty acids, bile acids and others are all described as regulators of host metabolism and gut barrier inflammation. The role of novel class of molecules called endosines is emerging. The concept endosines has recently been introduced and defined molecules originating from the gut which has the capacity to modulate duodenal contraction by targeting the enteric nervous system. See what happens is the duodenum contracts and then it forces the nutrients faster into the gut, and there the carbohydrates and others are increasingly absorbed. Again, emerging concepts are there. Now therapies, this probiotics, the therapy may revolutionize in future. It may change the course of diabetes, and here what is a recently new concept which has come is the fecal microbiota transplantation. Fecal microbiota transplantation is a useful treatment strategy for GI diseases with ineffective antibiotic treatment including ulcerative colitis. The role has been seen in ulcerative colitis, Clostridium infection and irritable bowel syndrome. It is very effective in the treatment of difficile infection, and 60% of patients were cured within a month without serious consequences. And intestinal transit time of patients receiving this intestinal flora was reduced, and the expression and plasma level of chemokine ligand were increased, implicating that the donor should be carefully selected in the treatment of FMT. Lot of talk has been done about the fiber, dietary fiber that has a helpful role, and here we have a Chinese study showing the benefits of fiber in the diet. Fiber is a prebiotic. Probiotics are generally gram-positive bacteria and defined as live microorganisms, which have already been told. Novel probiotics are there. Oral administration of Lactococcus lactis can reduce blood glucose and increase insulin concentrations in rats. Nevertheless, still a long way for clinical applications of probiotics in T2DM in future. Now talking about this, two randomized studies, they have done double-blind study, 45 patients with type 2 diabetes was studied in 6 weeks compared to fermented milk, and as you see, the fructosamine, hemoglobin A1C, LDL cholesterol and inflammatory cytokines has been reduced, and this is another RCT study showing randomized control study of 62 patients, 6 weeks exposure to symbiotic food. And here also we find that they reduce the serum insulin, there is reduced fasting glucose, C-reactive protein and reduced glutathione. Therapies based on T2 EM based on gut microbiota. Exercise, it has been found that exercise increases the level of good bacteria. And here you see what happens when metformin is given. Since the insertion of metformin in mid-20th century, see, metformin also has got some effect on the bacteria, and they promote the hypoglycemic effect of metformin. Now, this slide has been taken. You see, as far as the complications are concerned, in diabetic nephropathy, studies have shown that both prevention and progression of the disease is prevented. In retinopathy also favorable, neuropathy is favorable, and cardiovascular disease is favorable, and coronary artery disease also favorable, and peripheral vascular disease also good role, and incidence of amputation, gangrene, that has been reduced by the use of probiotics. Other drugs also like acarbose, dialister, acarbose. Now coming to the summary, previous studies have identified a decrease of butyrate producing bacteria and Faecobacterium, and all these, they are common in T2D, which may be the principal cause of T2DM. Now there are a lot of other things are mentioned, but I would like to end by giving a message that although probiotics has not been considered recently in the diabetic studies, but they may revolutionize the further course of treatment of diabetes, and sometime maybe 10 years the complications may markedly be reduced. Thank you very much.
Thank you, sir. So one question is there is any literature or research paper, can gut microbes affect pre-diabetic persons for being a diabetic? Can it stop or not?
Diabetes, pre-diabetes?
Yes. Can it stop for being a diabetic to a pre-diabetic person?
If you can try probiotics, but nobody has come with a concrete suggestion that probiotics can be given for pre-diabetes. Nobody.
There is.
Ask the dietitians in the audience whether they have any experience about the probiotics.
Thank you, sir.
There is one report which suggests that the dietary fiber we consume in a normal subject or in a diabetic subject, this fiber, if the carbohydrate is rich with the dietary fiber, this can change the flora of the gut. Rather, you can have a diversity in the gut flora, and since it is being linked to the metabolic syndrome, diabetes and other non-communicable disease, so might be change in the gut flora may be beneficial to prevent this non-communicable disease.
Sir, is there any study in which fecal transplantation has any role in changing the course of action of diabetes? Fecal transplantation, which is used for different diseases like IBS, IBD. So is there any study in which fecal transplantation is used to modify the course of diabetes? Any study?
I didn't get that.
I also could not get, please.
Sir, fecal transplantation studies which can modify the course of action of diabetes. Like nowadays, fecal transplantation is used as a treatment modality for IBD, IBS. So is there any study in which fecal transplantation is used to change the course of action of diabetes?
Change the type of diabetes?
No. Sir, like actually, need of drugs, need of insulin.
Sir.
The effect of low all this biobusiness on the prevention of pre-diabetes, type 2 diabetes, heart disease is all speculative at the moment.
Yes, sir.
There is no definitive
Yes, sir. Okay, sir. Thank you.
Okay, sir. With next speaker is Mr. Dr. A.K. Arya, sir, from Jamshedpur, and he is going to talk about hypoglycemia in non-diabetic patient. And as we know, senior medical officer and HOD at Medical Department CSIR, Government of India, Jamshedpur. He will be present his topic, and I request him to come on the stage.
Good morning. A great morning to all of you, and respected chairpersons, respected moderator, sir. And at the outset, I would like to extend my hearty thanks to the organizing committee to give me this opportunity to present a paper today. In all the conferences which we have been attending for so many years, there is always a topic on hypoglycemia. But we wanted to have some other discussion today, so my topic today, can you give me the changer please? So my topic today is a bit different. I wanted to discuss hypoglycemia in non-diabetics. We are very familiar with hypoglycemia in diabetics, and also this today we wanted to have some different discussion. ये वाला बोला ना, चेंज नहीं हो रहा। Anyway, आप कर लो। हाँ। So to start with the definition, this is the definition by ADA. Types of hypoglycemia is it has been classified as severe hypoglycemia, documented symptomatic hypoglycemia, asymptomatic. So severe hypoglycemia is an event requiring assistance of another person to actively administer resuscitate process. Documented symptomatic is when it is less than 70 sugar level. Asymptomatic is asymptomatic but the sugar level is less than 70, and then probable asymptomatic hypoglycemia and relative hypoglycemia is the same. So levels of hypoglycemia, we know that level 1, if the glucose level is less than 70, that is level 1. It is alert value of hypoglycemia needs to be reported routinely. Level 2 is glucose value when it is less than 54, sufficiently low to denote serious major clinically important or clinically significant hypoglycemia. Level 3 is very low to be denoted as severe hypoglycemia, that is severe cognitive impairment requiring external assistance for recovery. Pathophysiology of hypoglycemia, we all know that it is the Whipple's triad, which includes like low blood sugar, then symptoms relieved by ingestion of sugar, and then characterized by neurocogenic symptoms. So Whipple's triad, whenever we discuss about hypoglycemia, Whipple's triad always comes into the picture. Common symptoms, we all know that autonomic symptoms are sweating, trembling, palpitation, hunger, anxiety. Neuroglycopenic symptoms are inability to concentrate, irritability after drowsiness, incoordination, speech difficulty, delirium. And we also have got some non-specific symptoms like nausea, tiredness, headache. So symptoms can differ with age. In children, the symptoms are basically different, and it is basically irritability, while older people experience more prominent neurological symptoms of hypoglycemia. Causes, as I told, that basically we will be concentrating on causes of hypoglycemia which is non-diabetic. So the drugs, we know that insulin, orals, steroids, others are like basically beta blockers, ACE inhibitors. Systemic illness can cause hypoglycemia, which are like critical illness, sepsis, MI, organ failure, very common in renal and hepatic failure, endocrinopathy, adrenal insufficiency, malignancy also, and especially when we discuss of malignancy, it is insulinoma, which is the commonest cause of hypoglycemia in non-diabetics. Non-islet cell, insulin receptor, high tumor burden, and others are like exogenous, accidental, serous, artifactuals are there like specimen collection, failure or some misconception, consumption, leukemia or erythrocytosis. So there are classes of causes which can cause hypoglycemia in non-diabetics. So this is basically non-OHA drugs which are known to cause hypoglycemia. Basically, fluoroquinolones are very common, and in that group, gatifloxacin plays a major role. There are documented evidence on it which depicts that gatifloxacin. There are various studies which causes hypoglycemia in non-diabetics. Pentamidine is there, quinine, indomethacin, artemer, lithium. So these are the drugs which may cause hypoglycemia in non-diabetics. Differential diagnosis we should always keep in mind when we are discussing hypoglycemia in non-diabetics, especially Addison's disease, adrenal crisis, alcoholism, anxiety disorders, cardiogenic shock also plays very important role. And the first, as part as revival is concerned, glucose concentration has always to be kept in mind. Hypopituitarism is there, insulin resistance is there, insulinoma and pseudo-hypoglycemia is there. So these are the various studies which have predicted that out of the ACE inhibitors, the most culprit is captopril, which in 1985 the first case of ACE inhibitor-induced hypoglycemia was reported. Since then, several reports and small studies have published the incidence of hypoglycemia associated with ACE inhibitor use, and so we should be very careful while using these ACE inhibitors, especially captopril. Even Lancet has also recorded, and the study shows that as many as 13.8% of all hospital admissions for hypoglycemia were significantly attributable to use of ACE inhibitors, and so we have to be very sensitized about this use of ACE inhibitors and captopril as far as the hypoglycemia is concerned. Again, Diabetes Care, ADA, has also recorded that another small study was done with ACE inhibitor, and it has also emphasized the cause of hypoglycemia due to the ACE inhibitors. Other drugs, beta blockers can cause or exacerbate hypoglycemia in some individuals either by worsening an elderly present hypoglycemic episode. The mechanism responsible for beta blocker induced hypoglycemia involves inhibition of hepatic glucose production, which is promoted by sympathetic nervous stimulation. In addition, adrenergic counter-regulation is diminished, and non-cardiogenic selective beta blockers such as propranolol are more likely to cause hypoglycemia than cardioselective ones like metoprolol. So propranolol is one of the culprits in the group of beta blockers which might cause hypoglycemia. Another drug is pentamidine. Pentamidine is used in the treatment of opportunistic infections associated with immunosuppressive Hypoglycemia is the most common metabolic abnormality observed within 5 to 14 days of initiating, and to the range of 6 to 40% of patients, pentamidine-induced hypoglycemia is caused by an increase of insulin secretion via cytolytic response of the pancreas. Another is fluoroquinolones, which we have already discussed, and as I mentioned that this is gatifloxacin is very common cause of hypoglycemia in this group. Salicylate is another drug which might cause hypoglycemia, and salicylate-induced hypoglycemia is thought to be caused by several mechanisms like increasing insulin secretion in those with type 2 diabetes, increasing insulin sensitivity, displacing sulfonylurea from protein binding sites, and inhibiting renal excretion. So these are the list of few drugs which might cause hypoglycemia in non-diabetics. Alcohol, we all know it also plays very important role. Hypoglycemia associated with alcohol ingestion is a well-established problem in patients with diabetes. Patients who are treated with anti-diabetic agents such as insulin, sulfonylurea are at higher risk. The proposed mechanism of alcohol-induced hypoglycemia in a fasting and intoxicated patient is primarily the initiation of gluconeogenesis, and alcohol may also indirectly increase endogenous insulin secretion, contributing to hypoglycemic effects in non-diabetics. So how to manage? We all know 15-15 rule. We have to consume 15 gram of carbohydrates, wait for 15 minutes, then recheck the sugar. And again, if the sugar is less, again if the patient is in hypoglycemic state, we have to repeat the steps. And if it is increased by the first step, then we can have the normal diet, prescribed normal diet to outcome the hypoglycemic effect. This is again 15-15 rule to be applied maximum 3 times. If it is the patient is not recovered, glucose level is not coming to the optimum, then we can give 1 milligram of glucagon IM stat. Note, glucagon may be less effective if alcohol is caused. So alcohol cause is there, then glucagon has got lesser role to play, and 150 to 200 ml of 10% of glucose IV over 15 minutes bolus can be given. Management of unconscious, if unconscious patient is there, as we know the standard thumb rule is ABCD, airway, breathing, circulation, this GCS score, and of course exposure safeguard by temperature and back. So management of hyperglycemia, as we have already discussed, repeat after 10 minutes, and if it is coming up, then it is okay. So there are certain guidelines. Guidelines are by the Endocrine Society about the hypoglycemic, and they have all labeled it like evaluate and manage hypoglycemia only in patients in whom Whipple's grad is documented, and the quality of evidence is very high in that. Review the history, physical findings, and all available laboratory data seeking drugs, clinical. So take a complete history. In that, the quality of evidence would be moderate. So number 3 is when the cause of hypoglycemia disorder is not evident, then measure plasma glucose, insulin C-peptide. It would be moderate. When spontaneous hypoglycemia episode cannot be observed, formally recreate the circumstances in which symptomatic hypoglycemia is likely to occur. Again, in continuation with the recommendation, in a patient with documented fasting or postprandial endogenous hyperinsulinemic hypoglycemia, negative screening for oral hypoglycemic agents and no circulating insulin antibodies are there, then it would be moderate. And tailor treatment of this. In all patients, we have to individualize the treatment process, so tailor the approach to the patient depending upon the cause of hypoglycemia. There are also surgical management procedure for managing hypoglycemia. So surgical resection can be curative for insulinoma. Surgery can be also elevate hypoglycemia in non-islet cell tumor. Partial pancreatectomy can be considered in patients with non-insulinoma pancreatigenous hypoglycemia, and results of selective arterial calcium stimulation testing has also found to be very beneficial. So friends, coming to the summary of my talk today, early management is key to preventing complications. Numerous pharmacological agents that are commonly used in patients with or without diabetes have the potential to alter serum glucose levels. Although drug-induced hypoglycemia is often mild, it is a serious concern when life-threatening symptoms lead to increased hospitalization and significant mortality rates. A comprehensive understanding and awareness of the drug mechanisms responsible for lowering serum glucose concentrations may allow for better prediction, and as doctors, do not panic, only respond. Of course, this my last statement is not only for hypoglycemia, this is for all situations and all attempts. Thank you so much.
Dr. Arya,
Sir,
Did you think that even after giving 3 doses of 15 grams of glucose, patient had not responded and you have given IV fluid? IV glucose means it is because of many factors. First was because the party is very much scared of giving glucose. Even if you have given instruction, they are not giving properly. Simple. Second, repeated vomiting or poor intake. And third, as you have already said, due to starvation status or alcohol-induced hypoglycemia, the response is very poor. And fourth, is most important is if the patient is already on oral hypoglycemic agent, especially long-acting oral hypoglycemic agent, then there is chances of recurrent hypoglycemia. So you have to give IV glucose for a long time.
yeah,
Thank
very
you.
true, very true.
So,
Sorry.
Dr. Arya, yeah, very, very balanced, informative, and elaborated talk
Thank you, sir.
regarding hypoglycemia.
Thank you.
We also know that hypoglycemia is a medical emergency,
Yeah.
and each and every physician sitting here have encountered a case of hypoglycemia in their practice. So many times they may have
Very true.
faced that.
Very true.
But maximum cases we encounter in our practice is diabetic related hypoglycemia, maybe iatrogenic, maybe drug induced, treatment related. But non-diabetic hypoglycemia we see very less. And you have described that many drugs like salicylate, quinolones, and this alcohol and anti-malarials, they all can cause hypoglycemia. So this thing we must keep in our brain when treating a case of malaria, or when a patient comes with history of alcoholism or alcohol intake, we should think about hypoglycemia. The other thing, you told very nicely that in cases of hypoglycemia, we should start with oral rule of 15. Yeah. We should give some 15 gram of glucose. We
If
should
the
wait.
patient is conscious.
Yeah, if patient is conscious, right.
Yeah, yeah.
But you have also mentioned that in case of alcoholic induced hypoglycemia, we should not give glucagon.
Yeah.
Can you just describe why?
No, it has been mentioned, the data has shown that glucagon is not contraindicated in alcohol-induced hypoglycemia, but the expected response from glucagon due to the alcoholic hypoglycemia will not be that adequate as we will get the response to hypoglycemia, which is the reason is non-alcoholic.
It's absolutely.
Yeah.
One thing just I want to add.
Hello.
When a patient is alcoholic and he has hypoglycemia, in fact, from long period, he is not eating properly,
Right.
taking only alcohol,
Yeah.
so his glycogen depleted.
Yeah.
So in that case, if we use glucagon, probably there will be no glycogen, so no glycogenolysis, so no increased level of glucose, and probably it will not help. Yeah.
That is one. And in all cases of hypoglycemia, the history, the patient presents either history of confusion, or there may be seizure, or there may be reduced sensorium. So in all such cases in our clinical practice, we must think a cause may be of hypoglycemia. So this is all about.
Similarly, the use of epinephrine is not indicated in such cases. Because of long starvation causes practically loss of restored glycogen. So even if you are going to give epinephrine, or similarly like that of your drug, the effect is not proper because glycogen is already exhausted. And this alcohol already prevented the formation of neogenesis. So the patient is not affected. So you have to give glucose, there is no alternative in those cases.
Any questions from audience, please?
Exactly, sir, exactly. Vitamin B is very important, yeah.
Mike.
Thank you. Educating the family is extremely important because the person would not know what is happening. I was discussing with Dr. Veermani that I am concerned how many people have cardiac arrhythmia and sudden cardiac death because of hypoglycemia, especially the nocturnal one. And he gave cited example of a surgeon who died because of hypoglycemia. So very important that the family must be educated. Just like that, whatever patient we discharge from after angioplasty, bad LV, we always give a line, highlighted line, that all those patients should know CPR. All those patients should know CPR, learn CPR by opening a web link. So this is very important. Similarly, in diabetic, hypoglycemia is an emergency and the patient's family and surrounding must have proper education. Thank you.
I very much agree with sir that family counseling is very important, family education is important, and the best result would be that repeated hypoglycemia would be prevented if we educate the patient and the family. Thank you so much.
Thank you, Dr. Arya.
Thank you, sir.
Doctors,
Thank you so much, sir. And I will request you to kindly remain on the stage.
Now that this CM is, this program is concluded. Thank you everybody for good participation.
Thank you so much to each one of you. I would request all of you to kindly remain on this stage as we are going to have a very small and brief felicitation ceremony. आप सभी परम आदरणीय चेयरपर्सन्स और हमारे परम आदरणीय मॉडरेटर से अनुरोध है कि आप लोग कृपया करके मंच पे ही बने रहें क्योंकि एक बहुत ही छोटा सा सम्मान समारोह हम लोग यहाँ संपन्न करने वाले हैं और रिक्वेस्ट ऑल ऑफ यू टू काइंडली रिमेन विद अस। और हमारे बीच जो हमारे स्पीकर हैं डॉक्टर AK आर्या सर, मैं चाहूँगी कि आप जहाँ कहीं भी हैं आप प्लीज़ मंच में ही बने रहें। और इनके साथ साथ मैं हमारे बीच आज के इस प्रथम सेशन के बाकी सारे वक्ताओं को भी मंच पे आमंत्रित करना चाहूँगी। आई वुड रिक्वेस्ट डॉक्टर राहुल कुमार सिंह सर along with Dr. R.R. Verma sir, along with Dr. N.C. Singhal sir to kindly come upon the stage once again. I request each one of you to kindly come upon the stage once again. I will request all these speakers to kindly come up on the stage once again. और आप सभी देख पा रहे हैं हमारे बीच हमारे जितने भी चेयरपर्सन हैं उन सभी को अब सम्मानित किया जा रहा है हमारे स्पीकर्स के माध्यम से, उनके द्वारा। एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से। थोड़ी शानदार तालियां सभी लोगों की ओर से। और अब हमारे जो मॉडरेटर हैं इस पर्टिकुलर सेशन के, यानी कि डॉक्टर आर के मोदी जी, मैं उनसे अनुरोध करूंगी कि हमारे बीच सभी स्पीकर आज के इस सेशन के चारों ही वक्ताओं को वो सम्मानित करें। एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से। और आप देख पा रहे हैं हमारे सभी स्पीकर्स को, सभी चेयरपर्सन्स को और हमारे मॉडरेटर को, जो कि आज के इस सेशन को मॉडरेट करे थे, सभी को सम्मानित किया जा चुका है। मैं आप सभी लोगों से रिक्वेस्ट करूंगी कि आप लोग प्लीज आगे आ जाएं फॉर अ ऑफिशियल ग्रुप फोटोग्राफी सेशन। आई रिक्वेस्ट द मॉडरेटर ऑफ आवर सेशन टू काइंडली ज्वाइन। मैं आप सभी लोगों से रिक्वेस्ट करूंगी कि आप प्लीज़ आप लोग मंच में ही बने रहें, क्योंकि एक ऑफिशियल ग्रुप फोटोग्राफी सेशन जो है यहाँ इस वक्त होने वाला है। एक बार तमाम लोगों की ओर से तालियां आनी चाहिए, शानदार तालियां। हमारे प्रथम सेशन में इन सभी का एक बहुत ही अमूल्य और महत्वपूर्ण योगदान रहा है। हमारे तमाम माननीय चेयरपर्सन्स, हमारे माननीय मॉडरेटर और हमारे अत्यंत ही प्रखर वक्ताओं का, जिन्होंने अपनी जानकारियां, अपना ज्ञान हम सभी के साथ साझा किया। एक बार फिर से आप सभी को बहुत बहुत धन्यवाद। और इसी के साथ अब हम लोग अपने फर्स्ट सेशन को कंक्लूड कर रहे हैं एंड वी आर ऑल सेट टू बिगिन आवर सेकंड सेशन, विच इज बेस्ड ऑन द थीम ऑफ क्लिनिकल कार्डियोलॉजी।
Good morning, everyone. We are already late in the first session by almost 30 minutes. So I announce the second session, and the second session is the clinical cardiology, and for which the moderator is none other than Dr. Professor A.N. Rai sir. I request Professor Rai sir to come on the dais.
एक बार शानदार तालियां आनी चाहिए। डॉक्टर A.N. Rai is going to moderate this particular session, which is going to be the second session. And as chairpersons for this particular session, I would now like to call upon Dr. S.K. Goenka sir from Bugusarai, Dr. Ashok Kumar Gupta sir from Bugusarai, along with Dr. N.K. Nawal sir from Gaya, and Dr. Priya Ranjan ma'am from Bugusarai. I would request all four of you to kindly come upon this stage as the respective chairpersons for this particular session. And I would now request the honorable chairpersons as well as the honorable moderator of this particular session to kindly introduce all of us to all these speakers and about their respective topics on which they are going to speak. Thank you.
Thank you. Good evening, everybody. We are going to have a second session But before we start second session, I will request a speaker to stick to the time. We are already late, and we want to conclude this session within the allotted time. So, without wasting time, now we are going to invite the first speaker of this session, Dr. D.P. Khaitan. I request chairperson to invite Dr. D.P. Khaitan and introduce Dr. D.P. Khaitan.
हाँ, हेलो। हम आप सभी को नेशन ऑफ द प्राउड रामधारी सिंह दिनकर के जन्मभूमि पर स्वागत करते हैं। सेकंड सेशन स्टार्ट होने वाला है। स्पीकर्स आर वेल लर्नेड and moderator is nothing but our father of this CCDSI, Dr. N. Rai. So now you listen this.
ठीक है।
The speaker is प्रोफेसर डॉक्टर खैतान साहब। इनको कौन नहीं जानता। सवेरे सवेरे उठते हैं तो इन्हीं की ईसीजी पर हम लोग की नजर जाती है। तो नथिंग टू से मोर अबाउट द डॉक्टर खैतान। डॉक्टर खैतान विल स्टार्ट द क्वेश्चन।
आदरणीय प्रोफेसर डॉक्टर एन सर, मेरे पत्र निर्देशक और मॉडरेटर ऑफ द सेशन, मंच पर आसीन हमारे आदरणीय माननीय चेयरपर्सन सर, आज का विषय हमारे लिए होगा फंडामेंटल लॉज फॉर ईसी एनालिसिस। क्या मौलिक आवश्यकता है एक ईसी को व्याख्या करने के लिए। नेक्स्ट प्लीज। नेक्स्ट। मेरे ख्याल से कार्डियक इलेक्ट्रोफिजियोलॉजी है, उसको संक्षिप्त में समझना इसके लिए अति आवश्यक होगा। आप इसमें देखें, हृदय कोशिकाओं के चारों तरफ धनात्मक ऋण विभव पॉलिटी और अंदर में ऋणात्मक ऋण पॉलिटी रहती है। इसे पोलराइज स्टेट कहते हैं। एक सिंसाइडियम है, एक दिशा के साथ इसमें करंट का फ्लो होता है, ताकि बाकी जो नेगेटिविटी स्टार्ट होती है वो ऐसे होती है कि सोडियम आयन जो बाहर की ओर है वो अंदर प्रवेश करता है और पोटासियम आयन वो बाहर की ओर। तो पहले पोटासियम सोडियम आयन जो प्रवेश करता है उसके अंदर डिस्टर्ब पॉलिटी हो जाती है। बाहर का पॉजिटिव जो है वो नेगेटिव हो जाता है और एक पोटेंशियल डिफरेंस बन जाता है। उससे प्रवाह जो है फ्रॉम नेगेटिव टू पॉजिटिविटी, ताकि बाकी कोशिकाएं भी नेगेटिव की ओर जा सकें। यह जीरो स्टेज कहलाता है। इसका उद्देश्य होता है कि इंडोकार्डियम से एपिकार्डियम तक समान रूप से विभव हो जाए, ऋणात्मक विभव हो जाए, ताकि बाकी के स्टेज में आने में सहूलियत हो। जो जीरो स्टेज होता है उसके बाद जो वन स्टेज आता है उसमें क्यूआरएस वेव जो होती है उसके डिसेंडिंग लिंब पर एक क्षणिक रूप से पोटेशियम लॉस होता है। उस क्षणिक रूप से पोटेशियम लॉस के कारण एक वेव बनती है जिसे जे वेव कहते हैं, जे वेव, जंक्शन वेव कहते हैं। और उसके बाद जो है ऐसा होता है कि पोटेशियम तो बाहर जाता है, लेकिन उसने क्वांटम में उसी पॉलिटी में कैल्शियम आयंस भी अंदर जाता है। दोनों के बीच इक्विलिब्रियम बन जाता है, आइसोइलेक्ट्रिक लाइन बन जाती है, ताकि यही स्टेज है जिसके अंदर मायोकार्डियल कंट्रैक्शन होता है, हार्ट का कंट्रैक्शन होता है। अगर हार्ट का कंट्रैक्शन नहीं होगा तो हम लोग एसिस्टोल चले जाएंगे। ऐसा स्टेज बना है कि इसमें कोई कंपन नहीं हो, आइसोलेटेड स्टेट है, जिसे एसटी सेगमेंट कहते हैं। उसके बाद जो है कुछ ऐसा प्रोसेस होता है जिससे स्लो आयंस पोटेशियम का स्लोली जो है रिलीज फ्रॉम इनसाइड टू आउटसाइड अगेन होता है, जिसके पोटेशियम डिफरेंस के चलते एक वेव बनती है जिसे टी वेव कहते हैं। और टी वेव कंडीशन जब हो जाता है तो उसको नॉर्मलाइज करने के लिए एक पंप है जिसे सोडियम पोटेशियम एटीएस पंप कहते हैं। उसके माध्यम से विपरीत प्रतिक्रिया होती है और फिर पोलराइज स्टेट हो जाता है। इसे समझना इसलिए आवश्यक है कि एम्पलीट्यूड ऑफ द वेव इज डायरेक्टली प्रोपोर्शनल टू द क्वांटम ऑफ द वोल्टेज ग्रेडियंट आर एंड टी। क्वांटम ऑफ द वोल्टेज ग्रेडियंट का मतलब ये हुआ कि अगर वोल्टेज ग्रेडियंट अगर ज्यादा होगा तो हाइट एम्पलीट्यूड ज्यादा होगी। इसलिए होगी कि जीरो फेज में जो पोटेशियम सोडियम एंट्री होती है वो रैपिडली होती है, बहुत रैपिडली होती है और सोडियम की मात्रा अंदर जाने से पोटेंशियल डिफरेंस रैपिडली क्रिएट होता है, न्यूरो कॉम्प्लेक्स बन जाता है। जबकि टी वेव के साथ स्लोली होती है, स्लो एग्जिट, जिसको स्लो के एग्जिट फेनोमेना कहते हैं। उसके चलते स्लो होता है, इससे पोटेंशियल डिफरेंस कम रहता है और वेव की
मोटाई जो है वो क्यूआर से ज़्यादा होती है, लेकिन लंबाई जो है वो एम्पलीट्यूड कम होता है उसमें। ये चीज़ है। दूसरा है कि नो वोल्टेज ग्रेडियंट, नो क्वेश्चन करंट फ्लो। अगर कोई वोल्टेज ग्रेडियंट नहीं है तो करंट फ्लो हो ही नहीं सकता है। जैसे कि एसटी सेगमेंट में क्योंकि आइसोलेटेड लाइन है, सोडियम और ये पोटासियम और कैल्शियम के बीच में इसमें कोई इलेक्ट्रिक फ्लो नहीं होता है। अंदर प्रक्रिया चलती है, अंदर करंट इलेक्ट्रिक एक्साइटेशन कपलिंग करंट चलते रहता है, वो बात दूसरी होती है। इस तरह टीपी फिनोमेना जब कंप्लीशन प्रोसेस खत्म हो जाता है तब भी फ्लो नहीं होता है और एक आइसोलेटेड लाइन बन जाती है, टीपी फिनोमेना कहते हैं। और टीपी सेगमेंट के सही द्वारा हम लोग बाकी सेगमेंट्स ऊपर नीचे कर सकते हैं, वो जज किया करते हैं। और एक होती है कि width at the width depends upon the rate of the ionic flow. जल्दी होगी width will be smaller, narrow complex, otherwise will be wider complex in the case of the T compared to the QRS complex. Next please. ये देखिए इसमें डायग्राम्स बताया गया है, इसमें है करंट फ्लो फ्रॉम नेगेटिव टू पॉजिटिविटी जा रहा है, करंट की रिडक्शन है, करंट फ्लो ड्यूरिंग डिपोलेशन, पॉजिटिव रिफ्लेक्शन टुवर्ड्स द फ्लो ऑफ करंट, नेगेटिव रिफ्लेक्शन व्हेन इट इज अवे फ्रॉम द फ्लो ऑफ द करंट। मैं जा रहा हूं पॉजिटिव कर पीछे की ओर इस तरफ फ्लो हो रहा है तो पॉजिटिव नेगेटिव करंट फ्लो रिकॉर्ड कर। नेक्स्ट प्लीज। ये दो धरातल पर चूंकि हृदय है वो सूर्य की भांति सब दिशा में अपनी किरणें भेजता है। लाल लाल पिंड लाल सूर्य का गोला उत्तरा विमांचल में 90 लेयर गोला लाइक दैट। वो सूर्य नोड जो है सूर्य की माफिक है सब जगह भेजता है, लेकिन दो फ्रंटल प्लेन पर, एक फ्रंटल प्लेन जो होता है इसे वर्टिकल प्लेन, एक हॉरिजॉन्टल प्लेन या प्रिकोडियल प्लेन या स्ट्रेट प्लेन कहते हैं, उस पर रिकॉर्डिंग सब हो सकती है। ये जो है हम लोग फ्रंटल प्लेन रिकॉर्डिंग करते हैं वो बाइपोलर लीड्स, यूनिपोलर लीड्स, 6 लीड्स के माध्यम से 1 2 3 कम्युनिकेशन जो है बाइपोलर लीड्स का है और बाकी एवीआर एवीएल एवीएफ जो है यूनिपोलर लीड्स का है। इसमें कम्युनिकेशन है दो, इसमें पोटेंशियल डिफरेंस ठीक है, लेकिन एवीएल के रिकॉर्ड करने के लिए तीनों लिम्स के सेंट्रल पार्ट्स लगा देते हैं, जीरो पोटेंशियल बनता है और हम जीरो पोटेंशियल के आधार पर ही इसका डिफ्लेक्शन तय करते हैं यूनिपोलर लीड्स में। बाइपोलर लीड्स की जरूरत नहीं पड़ती बिकॉज़ देयर आर टू लिम्स, टू लीड्स देयर। आप देखेंगे कि एवीआर एक जो है वो अपोजिट डायरेक्शन में है फ्लो। यूजुअली जो फ्लो ऑफ करंट होता है मैक्सिमम पॉजिटिव एक्सेप्ट फ्यू सर्कमस्टेंसेस अदर प्लेन्स में अदर लीड्स में होता रहता है फ्रंटल में एक्सेप्ट एवीआर। आप देखेंगे एवीआर में ऊपर देखिए एवीआर में हर एक चीज माने वेव्स जो है नेगेटिव है। आइसोलेट यू नो लेटर ऑन हर एक वेव चाहे पी वेव हो या क्यूआर सो टी नेगेटिव है। अगर पॉजिटिविटी हो जाती है समथिंग लाइक पी वेव पॉजिटिविटी और क्यूआर पॉजिटिविटी और टी वेव पॉजिटिविटी, इसका डिफरेंस इसका मीनिंग बन जाता है एंड वी हैव टू कॉज ऑफ दैट। ये इसका है। और प्रिकोडियल लीड्स में क्या चीज होता है कि प्रिकोडियल लीड्स का कांसेप्ट दूसरा है। इसमें टुवर्ड्स द 90 डिग्री रूल होता है, डेट आई से लेट यू नो, लेकिन प्रिकोडियल लीड्स में फ्रॉम द थिनर वेंट्रिकल देयर इज राइट वन थिनर वेंट्रिकल से थिकर वेंट्रिकल का फ्लो होता है, बीच में ट्रांजिशन जोन होता है। अगर राइट वेंट्रिकल थिकर हो गया तो आर वेव इसमें हो जाएगा राइट हाइपरट्रॉफी में, अगर ये थिकर हो तो इसमें ज्यादा हो जाएगा। ये कहने का उद्देश्य मेरा इसमें है। नेक्स्ट प्लीज। अब फंडामेंटल लॉ जो है आप एक मान लें कि इंडोकार्डियम से करंट चला, सब इंडोकार्डियल से चला टुवर्ड्स एपिकार्डियम तक। जब एपिकार्डियम पहुंचता है तो एपिकार्डियम की जो एक्शन पोटेंशियल की जो अवधि है वह छोटी होती है कंपेयर टू द इंडोकार्डियल एक्शन पोटेंशियल की अवधि से। इस वहां पर तुरंत स्टार्ट होता है, जैसे स्टार्ट। और दूसरी बात यह है कि ये जो एपिकार्डियल करंट पहुंचता है वेंट्रिकुलर डिपोजिशन का वो पोस्टरोबेसल पार्ट ऑफ द लेफ्ट वेंट्रिकल पहुंचता है और वहां से जाके एंटरली जाता है इन द डायरेक्शन ऑफ द क्यूआरएस। इसलिए टी वेव इज पॉजिटिव, टी वेव इज पॉजिटिव। ये उसको समझाया गया, ये बड़ा इंपॉर्टेंट है क्योंकि सम टाइम्स होता क्या है कि किस तरह से सब कार्डियल जो करंट का फ्लो है वो डिले हो जाता है तो उसमें कार्डियल से शुरू हो जाता है अपोजिट डायरेक्शन से और टी बिकम्स नेगेटिव, एसटी बिकम्स नेगेटिव। उसका सिग्निफिकेंस ये है देखने में छोटो करे घाव करे गंभीर। नेक्स्ट प्लीज। इसमें देखिए द यू वेव का पोजीशन, यू वेव का नाम सुना होगा आपने। इसमें मत में विभांतर है, अंतर है लोगों के मत में। इसको लोग कहते हैं कि इसकी जो ओरिजिन होती है वो जस्ट एक मैकेनिकल फोर्स है आफ्टर पोटेंशियल फोर्स मैकेनिकल फोर्स लेफ्ट वेंट्रिकल वाल होता है, उसके चलते इको रिफ्लेक्ट है। दूसरा कहता है कि डिलेड डिपोजिशन ऑफ पर्किंजी फाइबर्स है। एक थ्योरी कहती है कि देखिए जो ट्रांसवर्सल जोन है उसमें तीन तरीके से होती है, सब इंडोकार्डियल सेल्स, बीच में एम सेल्स, मिड सेल्स एंड उसका सब एपिकार्डियल सेल्स। मिड सेल्स का डिपोजिशन, ये डिपोजिशन लास्ट में होता है, उस कारण जो कुछ लोग कहते हैं कि ऐसी बात होती है। ये फंडामेंटल चीज को जानना जरूरी है। अगेन हाउ आई शैल एक्सप्लेन इट, यू नो प्लीज। ये बात इंपॉर्टेंट चीज है, इसको याद करके रखना चाहिए दिमाग में। ये घड़ी है, इसको हम इसी घड़ी के नाम से पुकारते हैं, पर्सनल माइक कंसेप्ट। इसमें है कि अगर कोई करंट, आप देखिए आप ट्रांजिस्टर पर जो जाते होंगे, ट्रांजिस्टर के पर्टिकुलर डायरेक्शन रखने पर उसके आवाज ज्यादा सुनाई पड़ती थी, वहां से डायरेक्शन ट्रांजिस्टर चेंज कर दिए तो आवाज में सुनाई देता है। ठीक उसी तरीके से जिस डायरेक्शन में एवरेज इलेक्ट्रिकल फ्लो ज्यादा होता है, उस डायरेक्शन में उसका वेव का रिकॉर्डिंग ज्यादा हाइट के साथ होता है। इस डायरेक्शन को कहते हैं कि इलेक्ट्रिकल एक्सिस। एक मैग्नेटिक एक पर्टिकुलर डायरेक्शन है, मैक्सिमम मैग्नीट्यूड, इसको इलेक्ट्रिकल एक्सिस कहते हैं। इलेक्ट्रिकल एक्सिस का डिटरमिनेशन करने के लिए कानून बना है, इसका नाम है कि अगर आप देखिए पूरे फ्रंटल लोब, इट इज फॉर द फ्रंटल लोब, फ्रंटल प्लेन। अब आप उसमें देखिए मैक्सिमम डिफ्लेक्शन कहां होता है। इस केस में मैक्सिमम डिफ्लेक्शन जो है इसमें है D2 में, तो मैक्सिमम हर एक 30 डिग्री पर है। आप देखिए कि D2 का डिफ्लेक्शन ज्यादा है हमेशा के लीड ABF का 90 डिग्री पर, सो इलेक्ट्रिकल एक्सिस इज द नियर अबाउट प्लस 70 डिग्री। इसलिए इसको डिफरेंशिएट करने के लिए आप देखिए अरे इस में नेगेटिव आ गया कि पॉजिटिव, माइंड कंफ्यूज हो जाता है। इस कंफ्यूज के इंतजार को तोड़ने के ख्याल से इसको समझना बहुत जरूरी है। इसका फंडामेंटल है एनी एक्सप्लोरिंग इलेक्ट्रोड बेस्ड विद द 90 डिग्री ऑफ द electrical axis, it will record the positive wave. At the equiphasic phase, it will record the either no reflection or equiphasic diffraction. And if it is away from the 90 degree, it will record the negative reflection. आप यहाँ पर 90 डिग्री है, हम सामने देख रहे हैं। बियॉन्ड 90 डिग्री क्या 90 डिग्री क्या दिख रहा है? एक ब्लैक स्पेस में आएगी सामने, तो इट इज रिकॉर्डेड बाय द नेगेटिव वेव। लाइक दैट यू कैन अंडरस्टैंड वेरी इजीली। नेक्स्ट प्लीज। आप इसमें देखिए जस्ट पी क्वालिटी एक वेव क्या दिखाया हमने। P is known as the जिसे ventricular deposition है, इसे ventricular atrial deposition भी होता है, atrial deposition भी होता है। atrial deposition को देख नहीं पाते हैं, इसका atrial deposition का वेव इतना छोटा होता है, इतना प्रॉक होता है कि यूरास के तले छुप जाता है, उसके छांव में छुप जाता है और atrial deposition वेव में नजर नहीं आता है। P वेव जो है atrial deposition वेव है, Q सेप्टर वेव है। जो आप देखेंगे लेफ्ट बंडल ब्रांच और राइट बंडल ब्रांच में पड़ता है, तो लेफ्ट से एक वेव चलती है towards the this side. So negative wave is the away from the recording base to produce the negative Q wave as a full negative Q wave to capture receptor wave. R is the maximum flow of the current. S है कि away from the direction जाते S wave करता है। एक्चुअली जाता है फ्लो ऐसे जाता है, ऐसे जाता है, एपेक्स में फिर ऐसे जाता है नेगेटिव डायरेक्शन में। What's the positive pressure part? इसको नेगेटिव दिखाया जाता है। ये सब आइसोलेटिक पार्ट जो है ST सेगमेंट का है, जहाँ पे बता चुका हूँ मैं कि वेंट्रिकल कंट्रैक्शन का होता है। T वेव क्यों पॉजिटिव बता चुका है, बता चुका हूँ, और U वेव क्यों पॉजिटिव होता है ये बता चुका हूँ। नेक्स्ट प्लीज। P wave normal duration is less than 0.12 second, 3 small squares, amplitude less than 2.5 millimeter in the limb leads, less than 1.5 millimeter in the precordial leads. Q wave pathological becomes pathological Q wave when its width exceeds the 0.04 second wide or more than 25% of the depth of the QRS complex. It may be seen, usually normally Q wave may be seen in leads V1 to 3, but maximum maximally in lead V1 to V2 known as QS wave. PR interval is 0.1 to 2.20 seconds. QRS width 70 to 100 milliseconds, sometimes 110 millimeters. T wave amplitude less than 5 millimeters in the limb leads, less than 10 millimeters in the precordial distribution, related to QE interval. That's the main difference. I'm quickly going because कुछ चीज़ अच्छी चीज़ बतानी मेरे को और इससे ज़्यादा। Next please. Next please. आप देख लें वेट कैलकुलेशन। 1 सेकंड में 25 मिलीमीटर रनिंग होती है, तो 60 सेकंड में 8 मिनट में 25 into 60 इक्वल टू 1500। 1500 से डिवाइड कर दे, 2 आर के इंटरवल जितने स्मॉल हाउस है हार्ट रेट दे देगा। अगर प्रोवाइडेड की रिदम ऑफ द हार्ट जो है रेगुलर है, अगर रिदम ऑफ द हार्ट इज रेगुलर नहीं है, उस हालत में हम लोग 10 सेकंड्स में इस स्टेप में कितना काउंट क्लास का उसको डिवाइड करके उसको मल्टीप्लाई कर देंगे 6 से, तो 60 सेकंड्स बाय 1 मिनट हो जाएगा। तो डेट विल गिव द कैलकुलेशन द रिदम इफ द रिदम इज इरेगुलर, रेट ऑफ द रिदम इफ द रिदम इज इरेगुलर। नेक्स्ट प्लीज। ये एक नॉर्मल ईसीजी है, इसमें दिखाना मेरे को ये है कि ये वीआर जो देख रहे हैं उसमें सब नेगेटिव है। पी भी नेगेटिव है, क्यूआर भी नेगेटिव है, टी नेगेटिव बिकॉज़ इट इज अवे। That's why it is away. और दूसरी बात दिखाना चाहेंगे इसमें कि ये V1 को देखिए और V5 को देखिए, दोनों का अपोजिट क्वालिटी है। राइट वेंट्रिकल थिनर है, उससे लेफ्ट वेंट्रिकल की यात्रा हो रही है सिंसाइटियम के माध्यम से, जो कॉमन पाथवे है, सेपरेटेड नहीं है। सेपरेटेड हिस्ट्री जो कुछ और रहती है इसमें। नेक्स्ट प्लीज। अब यहाँ से हम लोग पढ़ेंगे कि इसका एप्लीकेशन क्या है। तो साहब ने इतना बताया इसका कार्डियक एप्लीकेशन क्या प्रैक्टिस में है। नेक्स्ट प्लीज। कुछ एग्जांपल दे रहा हूँ। नेक्स्ट प्लीज। नहीं है क्या पर? नेक्स्ट कीजिए। आप देखिए लेफ्ट एट्रियम के ऐसे नोड से एट्रियल वेव डिपोजिशन निकलती है, जिसका डायरेक्शन वर्ड्स द लीड टू रहता है। इससे पॉजिटिव वेव है। V1 में भी पहले पार्ट में ये डायरेक्शन वर्ड्स द V1 आता है, इससे पॉजिटिव वेव है। जो कि लेफ्ट एट्रियम पोस्टरली सिचुएटेड है, इसलिए रेस्ट ऑफ द पार्ट जब वेव जाएगी अवे फ्रॉम द डेड पाई जी, तो डेड विल बी रिकॉर्डेड एज ए नेगेटिव वेव। इसलिए जो लीड 1 में है वो फर्स्ट इज अ पॉजिटिव वेव, beginning of the left atrium, right atrium, and terminal beginning of the left atrium. ये इसका महत्व है। अबे सिग्निफिकेंस का महत्व है इन ब्रीफ। अब देखिए लीड 2 और V1 को रखता हूँ राइट एट्रियल एलिमेंट में। if the height of P wave is more than 2.5 in lead 2 is indicative of the right atrial enlargement, and if it is the same quantum if the initial wave is 1.5 millimeter. Why? Because there is difference in the space. That's why it is less in amplitudes. So it is 1.5 millimeter. If anything, either of the two, not always two, either the 2.5 millimeter. Yes. With these words, I would like to invite the questions. Thank you, sir. Okay, sir. I stop my lecture there, sir. Just to keep the honor and sincerity of the just want ventricular hypertrophy मेरे left ventricular hypertrophy towards left है, तो towards left V5 V6 में कुछ देखिए। रिवर्स जो है right ventricular hypertrophy में है, इसमें जो है रिवर्स देखिए, इसमें जो वहाँ पर V5 V4 में है वो V1 V2 में है। Only that thing. There are so many things to be explained, but due to positive time, I made excuse, sir.
Thank you, sir, for your excellent talk on the basic physiology of ECG. You are a master in ECG, sir. We always learn from you. Now I request Dr. N. Raya, sir, to.
Yes, sir. Any questions? Haan, sir.
Dr. Khaitan, for completing your ECG, basic of ECG in time. I think ECG is a fundamental of not only part cardiology for physician. Even all the modern we have got all the modern investigation in cardiology, but ECG, no one has replaced ECG. It is the basic and must for every person having any cardiac problem. And as Dr. Khaitan has said, basic of the ECG we understand. He has very well said that certain you get a positive wave or negative wave. It doesn't mean negative that it has got negative potential. It is the direction of the wave. If I am giving the example, in V1, you get a small R wave and bigger wave. What is the reason? Because in V1, the current which is coming towards the electrode, V1 is on the right side, and the current which is coming towards the electrode is from septum and right ventricle. So you get a small R wave, and the depolarization by the left ventricle is going away, and that's why you get a deep S wave. So a small R wave and deep S wave is a feature, and this is just because the right ventricle is thin, the current is coming towards the electrode and giving positive wave. So a positive or negative wave doesn't mean that a person there is a negative or positive potential. Similarly, in V5, V6, you get a small Q wave first. Why you get a small Q wave? First depolarization out of in the ventricle is septum. So septum is going away, a small Q wave V5, V6. Then you get a tall R wave because current is coming towards the electrode on V5, 6 on this side. So left ventricular current is coming towards the electrode, and then you get a S wave, and then due to right ventricular depression. Why in myocardial infarction you get a QS pattern? Why there is no positive wave? Because you regard the potential of cavity. In the cavity, you get all the potential current are going away. So you get a Q wave. Why in AVR? You get all current negative. Because the potentials are going all away. You are facing the cavity. So that is the reason. So positive and negative does not mean that the electrical current is, this has got positive and negative potential. It is just the direction of the electrode. And if the current is, electrode is placed in such a place where the current is coming towards the electrode, it will be positive. If it is going away from the electrode, it will be negative. Second is the ECG based on the machine. It is a 25 millimeter per second. You must know. And he has rate and potential 1 millivolt is 10. So these are the basic thing of the ECG. And I think in spine, I am saying that every clinician, whether he is MBBS, MD or cardiologist, they should know basic of the ECG. Because nowadays we are going to get the cases of heart attack, and heart disease is very common, and the person is living in the rural area. If he can diagnose the myocardial infarction and he can thrombolyze the patient in time, window period, he can save the life. Now I hand over mic to the speakers to invite questions.
Yes. If any questions, I shall welcome all these things. If any question.
Chairperson. Sorry, chairpersons. Chairperson, you can invite questions. And then we'll conclude.
I request the audience to, if they have any question, please put forward.
Thank you, sir.
The best part was that you spoke in Hindi. So you have almost translated the whole ECG basic aspect into Hindi. So you require to be congratulated. I am hearing for the first time somebody speaking in Hindi. Such a beautiful exposition of basics of ECG. So congratulations.
मैं आपका अभिवादन करता हूँ सर.
ECG जो है एक कागज का टुकड़ा मात्र नहीं है, वो हमारे हार्ट का एक जो शीशा है, हमारे हृदय का मिरर है. इस बात को समझना चाहिए सभी को. It is not only a piece of paper.
बड़ा सुखद संजोग है कि दो ECG मास्टर्स आज डैश पर मौजूद हैं. दोनों के बारे में कुछ कम कहा जाए तो ज़्यादा समझना पड़ेगा, क्योंकि दोनों में जो कुछ है सब कुछ है, ऑल इन वन है सब. ऐसा सुखद संजोग है कि दोनों आज डैश पर हैं.
Thank you, Dr. Vivekanand.
One second, sir. Here at this point, I would like to remind everybody that ECG can be abnormal in a normal person, and can be abnormal in a normal in an abnormal person. So one must take care of that. ECG is not the ultimate thing. It is the basic thing. Thank you.
Thank you, sir.
Thank you. Now I request the chairperson to invite the second speaker, Dr. Abhay Krishna.
Hello. I would like to welcome Dr. Abhay Krishna for next session, approach to chest pain. We welcome sir for our desk.
खतान साहब, थैंक यू सर, वेरी मच थैंक यू. खसान साहब ऐसे शख्स हैं, इनके अंदर जितना घुसिएगा उतने सीखिएगा, चाहे स्पिरिचुअल होवे चाहे एकेडमिक मटेरियल होवे. थैंक यू सर.
Hello. So good morning everybody, and my salute to Dr. Khaitan, who has such nicely explained this topic. So we very commonly encounter patients with chest pain. So let us see how we should approach to patient with chest pain. So chest pain you very commonly encounter in emergency department, and when you see almost 50% of the patients will have chest pain which is non-specific or non-cardiac chest pain. So it's not like that any patient who comes to you with chest pain will always have cardiac etiology or coronary etiology. It is very important. So 55% patients will have non-cardiac chest pain. So if you see the top 10 causes of chest pain which present in emergency department, if you categorize age-wise, so 18 to 44 years of age, you see that the non-specific chest pain remains common in all ages. But if you see the coronary cause, for 55 years onwards, the coronary cause becomes the second most common cause. So this is important to remember. So 10 to 15% of acute chest pain in emergency department can be unstable angina or ST elevation MI. And 8 to 10% patients are mistakenly discharged from ER. If a patient of chest pain comes to you, you do an ECG, it looks normal and you discharge the patient. Later on serial ECG, patient can have chest changes in the ST segment and can develop MI. So if you see the post-mortem analysis, it has 25 to 40% of patients who have been mistakenly discharged can have MI. And short-term MI mortality, if you do not admit, it's almost 25% of patients will die if you do not admit that patient. So we should consider the life-threatening cause of chest pain. So whenever a patient comes to you, is it only heart attack or something else? If you exclude the patient did not have heart attack, is it that it is time to relax? Are we comfortable if patient does not have coronary cause of chest pain? Is it sufficient? No. So is it enough to rule out heart attack? So non-coronary chest pain can also be fatal. Very important to remember. Do not think that a patient who does not have a coronary etiology can be non-fatal. So what are the life-threatening causes of chest pain? Apart from coronary, we all know acute coronary syndrome is the first. But aortic dissection, pulmonary embolism, tension pneumothorax, mediastinitis, esophageal rupture. These can also be important and can be life-threatening. This is very important to remember. And time is vital. Acute MI patient comes to you and you lose time in diagnosis, the prognosis becomes bad. With losing time, prognosis becomes on the worst aspect. So it's important to diagnose on time. So whenever a patient of chest pain comes to you, always assume the worst. Patient may have cardiac or non-cardiac, but assume the worst. Start 100% oxygen, get an IV access. You do monitoring, do ECG quickly within 10 minutes. Do a chest X-ray and do a troponin. And in between you quickly take the history, do a quick physical examination. So you do not need to waste time on these things. So cardiac or non-cardiac, that remains the biggest question whenever a patient comes to us, whether a patient is cardiac or non-cardiac. This is the question which has to be answered whenever you encounter a patient with chest pain. So if you see cardiac, there can be coronary, there can be non-coronary. A coronary patient can have unstable angina, STMI, or can have chronic stable angina. That can also come to you in emergency department, in your OPD. Non-coronary patient can have some sort of valvular heart disease. Patient can have pericarditis or myocarditis. So it's not like that all cardiac chest pains are coronary of origin. So there is a long differential diagnosis of non-cardiac chest pain. From respiratory, you see patients with pneumonia, pulmonary embolism, pleuritis. In GI, you see cholecystitis patients sometimes can present with pain, esophageal spasm, dyspepsia, GERD. Cervical radiculopathy can present like this. Costochondritis in young patients is very common. Anxiety patients, some patients have somatization disorders. So there is a large number of patients, there is a long differential diagnosis. But you have to be, in your approach, you have to think how you should proceed. So whenever a patient of chest pain comes to you, history is very important. A quick physical examination, ECG, cardiac enzymes, and chest X-ray. These are the things that can be done very quickly. But very important, history is the key to the diagnosis of etiology of chest pain. It will take you hardly 4 to 5 minutes to take history, but at 80-85% of times you will diagnose that patient has coronary, non-coronary, or non-cardiac cause of chest pain. So history is very important. And it has to be taken in all aspects. What is the nature of the pain, what is the location and duration of the pain, what is the onset and the duration of the pain, what is the severity of the pain, what are the aggravating and relieving factors, and what are the associated symptoms. So in all prospects, the history has to be taken. You cannot waste half an hour on that, but believe me, it will take hardly 4 to 5 minutes for you to take the history. So the classical chest pain is a retroexternal discomfort, more of discomfort than a pain. It's a squeezing type of pain. It's a tightness, it's a pressure-like sensation. And a sharp, stabbing, pricking, knife-like sensation is less likely coronary. Sometimes patient can describe chest pain as breathlessness. Patient may not have chest pain, patient can be breathless. So it is also important. So if a pain which is central, pressure, squeezing, gripping, heaviness, tightness, stress-related, retroexternal, that is a classical chest pain. It's a dull aching type of pain, it's a left-sided pain, where it's a sharp, fleeting, shifting pain, which is very constant from last 3 or 4 days lasting. It's unlikely cardiac. So it is very important to, and these are the different locations of pain. It can be only retroexternal, it can be only in jaw, it can be only in epigastrium, it can be only intrascapular, it can be only limited to neck and jaw. So don't think that the pain will always be of classical origin and classical description. So this is the typical pain which is central, retroexternal, left-sided chest pain radiating to the medial aspect of the left arm. But you may not always get these features. You may not have classical symptoms. So onset and duration is important. Angina symptom usually build in intensity over a few minutes. Very important. Patient will say that within a span of 4 or 5 minutes, the pain has started increasing and building up. By a sudden onset, ripping type of chest pain, it's more likely of acute aortic dissection. And in a fleeting pain, patient says that the pain is sometimes at this side and it goes to other side. That side pain is usually non-cardiac. So gradual onset over minutes during exertion is usually cardiac, but also remember the muscular pain will also occur after exertion. So it is important to remember. So history, what are the provocating factors? Exertion, emotions, large meals, cold winds, and rest symptoms usually indicate the patient has acute coronary syndrome, and that patient has to be taken care very quickly. So chest pain, other than cardiac causes, if you see a patient with pleuritic type of pain, the classical history that the pain, which is a sharp and catching type of pain, and which is exacerbation of a cough, deep inspiration or movement. That is classical or pleuritic or pericarditis of pain. Musculoskeletal pain will increase with a specific movement of the muscle. And also important is to consider the associated features. Dyspnea, palpitation, sweating, upper abdominal pain, nausea, vomiting, lightheadedness, pre-syncope or syncope. So massive pulmonary embolism and aortic dissection can also have autonomic disturbance. And also you should consider that in women, diabetics, elderly, symptoms on the left or right side of the chest, stabbing type of chest pain, or discomfort in the throat or abdomen. So these categories of patients will present with atypical features. So this should also be considered in more than 75 years of age. You see patient has ACS and has come to you with only acute syncope, patient has unexplained fall, patient has delirium. So these can also be unusual presentations in elderly patients. And sweating is a very important symptom. In ST elevation MI, usually you get a history of chest pain associated with sweating. So this history has also be considered. And relief with nitroglycerin is not necessarily diagnostic of myocardial ischemia. So in other etiologies, it should not be used as diagnostic criteria that pain is relieved by nitroglycerin. So history, as we have seen, pleuritic type of chest pain, the pain localized to the tip of one finger, pain with movement, a constant pain, fleeting type of pain, pain that radiates to lower extremity, these are unlikely cardiac. And always look for risk factors: age, diabetes, hypertension, dyslipidemia, male sex, history of prior MI, PCI or CABG. A quick examination is very important. Check the vitals, check the cardiovascular system, respiratory, abdominal, neurological status. Look for hypotension, tachycardia, pulmonary arrest, JVP, S3, pulmonary edema. Look for new murmurs, heart sounds, and diminished peripheral pulses, signs of stroke. So a quick history and physical examination is very important, and that should be targeted examination. So if you see an ECG, quickly see patient has ST elevation or not, patient has new onset left bundle branch block, patient has deep T inversions, suggestive of NSTMI, non-specific ECG, almost normal ECG, patient can have unstable angina. So if you see in this ECG, lead 1 AVL, V2 to V6, there is ST elevation, so it's an entry valve myocardial infarction. In the other, there is hyperacute T waves in precordial leads, again suggestive of hyperacute T waves and entry valve MI. And you see inferior valve ST elevation is 2, 3 AVF, there is ST elevation. This is inferior valve MI. So you must have some idea of ECG. There is diffuse global ST depression, ST elevation AVR, usually indicative of left main disease. And T inversion can be indicative of NSTMI. So there can be different ECG patterns. A patient when comes with acute coronary syndrome, usually when the artery is completely occluded, he presents with ST elevation MI. When the artery is not completely occluded, it can be non-STMI or unstable angina. When the troponin is positive, you call it NSTMI. Troponin is negative, you call it unstable angina. Most of the patients of ST elevation MI will develop later on Q wave MI. Some of the patients of NSTMI will develop later Q wave. So whenever a VSCS patient comes to us, we see that pain looks like of coronary origin. It is important to stratify the patient into low risk, intermediate risk and high risk. So let us see what are the high risk criteria. It is very important. Patient who has elevated cardiac markers, new ST depression, recurrent ischemia with heart failure, depressed LV function, hemodynamically unstable patient who has sustained VT, prior PCI, prior CABG. So these all patients come in high risk group. So a low risk group can be managed at chest pain center. Intermediate group, some of the patient might require invasive therapy, some can be managed on conservative ways, and high risk all of the patient in invasive therapy. So do not discharge such patients. So just in a ecstasious patient, you see typical angina, diaphoresis, tachycardia, look for a new murmur. In pulmonary embolism, most of the time patient will have tachycardia, dyspnea, pain with pleuritic type of pain. Aortic dissection, patient will have sharp chest pain, there will be pulse difference that can be wide, mediastinum, some of the patient can have syncope, some of the patient will present with MI. Esophageal rupture, patient will have emesis subcutaneous emphysema, neomediastinum. Pericarditis, the classical pain of pericarditis. In esophageal peptic ulcer, patient will have epigastric tenderness. Pneumonia, patient will have history of fever. You get the breath sounds. In pneumothorax, there will be dyspnea. In costochondritis, there will be localized tenderness. In herpes zoster, you will get a classical rash. So in different scenarios, history and physical examination is very important. Only by this you can make a diagnosis. So what is the general approach to the patient of ACS? Whenever patient comes to you, you do an ECG. So ECG should be done within 3 minutes and repeat ECG every 20 to 3 minutes until you say it's a non-cardiac or you make a diagnosis of acute coronary syndrome. If it is obviously non-cardiac caused by ECG, you make a diagnosis, then no further cardiac testing is required. If you see it's a possible acute coronary syndrome, then do a troponin. Time when the patient comes to you, troponin, then repeat after 3 to 6 hours. And use clinical decision pathways to stratify the patient into high risk, intermediate and low risk. So a low risk patient can be discharged, intermediate risk, further diagnostic testing, you do some non-invasive imaging also. And in high risk, all patients will need further invasive strategy, they will need further revascularization. So I will show some of the cases. 50-year-old male with retroexternal chest pain, heaviness, associated with profuse sweating from 2 hours. You do an ECG, see ST elevation, it's ST elevation, anti-LMI, patient needs immediate attention, needs immediate hospitalization, immediate angiography and vascular attention. Or thrombolysis if it permits. The second case, 78-year-old lady, sudden onset of fall, brought to emergency in drowsy state, pulse 60, BP, hypotension 80 by 50. You see the ECG leads, the ST elevation, this is classical presentation in inferior LMI scenario, ST elevation 2-3 ABF, and reciprocal ST depression. So this patient also needs immediate attention. A 33-year-old male with chest pain for 3 days, more on inspiration, turning to the left side while lying down. You see the ECG. Yeah, I will conclude just. So there is diffuse ST elevation. Always look for diffuse ST elevation and ST depression in AVR. This patient has pericarditis. That is not acute coronary syndrome. It is pericarditis. 40-year-old lady with chest pain localized to a sharp point, more on inspiration. So that is not classical of acute coronary syndrome. That is a non-cardiac type of chest pain. A 67-year-old hypertensive with sudden onset retrosternal chest pain, a repeat type of chest pain, low volume pulse in left side. You see there is associated inferior LMI, it's aortic dissection. Think in that way. 50-year-old male, sudden onset chest pain, shortness of breath. It could be tension pneumothorax. Obese lady, history of OCP, JBP, shortness of breath. Classical S1QT33 in ECG, it's acute pulmonary embolism. So different scenarios, 50-year-old lady with complaints of epigastric pain, nausea, vomiting. So diabetic patient can have atypical symptoms, it's inferior LMI, you do right, left, posterior leads, the associated inferior and posterior LMI. So just to conclude, chest pain is more than pain in the chest. Do a high sensitivity troponin test. Early care is required. And the decision making is important. Testing is important. The clinical decision pathways should be used. Look for accompanying features. Identify which are the high-risk patients. And nowadays, atypical chest pain no longer exists. You should say it's a non-cardiac type of pain. And there should be structured assessment. You do the risk scoring. Thank you very much.
Thank you very much for Dr. Avakish for your excellent presentation. I think he has very well said that all the chest pain are not due to cardiac origin. But here I would like to say the odd chest pain due to cardiac origin, especially due to coronary artery disease, are serious. So any doubt whether it's a cardiac or non-cardiac, you should always cover the cardiac, because if you miss a cardiac, you lose the patient. Especially a patient presenting with acute chest pain, there are few conditions which mimic. I have seen cases, patient presenting with the pain in the neck and radiation to the arm. You diagnose as cervical spondylosis commonest, but if the patient says that this is associated with in case of the insertion, associated sweating, always if there is a history of sweating or if there is a reaction to chest, cardiac should be covered. Because I lost a case, the patient was being treated for a cervical spondylosis by a physician. He presented with a chest pain in neck and arm, and his ECG was normal, but his pain suddenly deteriorated during the night, and he was brought to the hospital where we did the ECG. He had acute infarction, feature of acute infarction. So cervical spondylosis is one. Second is the few cardiac conditions which mimic acute coronary syndrome. He has very well said: acute pulmonary embolism, acute pericarditis, and dissecting aneurysm of the aorta. These are all also serious. But acute pulmonary embolism always occurs when there is an underlying predisposing cause, prolonged immobilization, postpartum, post-surgical. So if you have a suspicion, you can go for that. If there is a history of fever, everything, mimic pericarditis, ECG, there is generalized changes, not a localized regional changes for pericarditis. Dissecting is very deceptive. And if you do not treat timely, the patient will collapse. And falling BP, that the pulse will go on, BP is gradually going down and down, condition is deteriorating, always suspect that the patient with each beat, the patient BP is going down, there is likely to be dissecting aneurysm. So these, and especially dissecting aneurysm occurs in elderly, dissecting the hypertension. So these are the few cardiac deficiencies of acute coronary syndrome. Others, non-cardiac cases are pleuritic pain, pneumothorax, all this he has got, he has already said, and atypical pain. So with this, I request chairpersons to invite questions and conclude the session.
सर एक क्वेश्चन मेरा रहेगा आपसे सर, क्या हार्ट अटैक के केस में नॉर्मल ईसीजी की उम्मीद कर सकते हैं? सॉरी, हार्ट अटैक हुआ, एक्चुअल हार्ट अटैक है, मायोकार्डियल इंफार्क्शन हो रहा है उसको, in spite of that there is a normal ECG.
Yeah, definitely. What I told you, 8 to 10% of patients are mistakenly discharged with a first ECG which is normal, and so it is always better to admit such patients. Sometimes after 1 day of observation you may discharge with a non-cardiac, it is better. But if you mistakenly discharge a patient with normal ECG, patient lands up in MI, then that can have medical legal issues also, and that can have other issues also for the patient. So always it's better on a single ECG, do not comment that it is not MI.
Thank you, Dr. Abhay Krishna. Any question from the audience?
Hello.
Any question from the audience?
Question? Yes, sir. Yes, sir. Well done, Dr. Abhay, sir. Very nicely presented your topic. And my question has already been asked by Goenka, sir. So just I want to say, please give a clinical message to this hall. What should be done to reduce those 8 to 10% of cases that are mistakenly discharged because of inadequate or improper diagnosis?
Yes, it is always better to take help.
Always?
It's always better to take help.
Yeah.
If you work as a team, suppose a physician gets a patient with a suspect that it is normal, it can have MI.
Yes, sir.
If he sends the ECG to you, he sends the ECG to a cardiologist.
Yes, sir.
So there is no harm in sending the ECG to him and taking a second opinion.
Yes, sir.
So it's always better to take help. It is always better to admit that patient.
Yes, sir.
Do serial ECG, do serial troponin. Definitely. Always repeat these tests. Definitely. That might add to the cost of the patient. But ultimately, when you discharge after 24 hours, you are satisfied the patient has a non-cardiac origin. Otherwise, if the same patient develops acute MI after 4 or 5 hours and dies, then the consequences can be catastrophic.
Thank you, sir. That is the clinical message. So everywhere, if a patient is at rural site or if he or she cannot move to cardiologist, please admit those type of patients, do serial ECG, serial TROP-T, because these two things are available everywhere. And before discharging the patient, be sure the patient's chest pain has been subsided. Thank you.
Thank you, sir.
ECG is normal at that moment, and the symptom is not very characteristic, or because enzyme treatment is not available in the periphery area. So if the patient comes after 12 hours or 15 hours and the symptom is not very specific, then you can repeat it, then can patient be discharged, I hope.
You do a troponin also.
Yes.
So along with you do a troponin, we have seen some patients who have atypical symptom, elderly patients, ECG looks okay, and his troponin is 10. So this happens, this can happen. So all sort of patients.
Up to what extent you wait for ECG changes in most of the cases? Because it mostly comes positive in 4 to 6 hours.
Yeah, see that depends on what pathologically is going under. If a patient who has a non-occlusive thrombus, the artery is partially opened, ECG can remain normal for some time, and after 1 day or even after 1 or 2 days also it becomes a complete occlusion. What we call, some patients have pre-infarct angina. Patient can have some angina 2 days before landing into a frank MI. So none of the patient, you can be very sure that the patient will not have symptom. We have done angiography of a patient that was perfectly normal, and after
2 days after angiography, he developed acute MI. And then he asked, my angiography was normal 2 days back, how it is
you want
possible?
to ask question last?
Yes,
We
yes.
have got enough.
First, compliments, Abhay.
It's the last
compliments
question.
to you.
And we'll conclude.
And compliments to Dr. Verma also. My submission, humble submission, in addition to what doctors have asked, if the patient is not showing classical changes in the ECG, the enzymes or the biomarkers are not coming up, the only way out to go for imaging, do a CT. And what we have devised now in Patna, in our hospital, Medanta, we do a triple rule out CT. We give contrast, we see coronary, we see aorta, and we see pulmonary artery in one shot, one go.
Yeah.
And that gives us a clear picture.
I think
Thank
that's a good idea. Even if you can see coronary artery calcium, that is also sort of non-invasive. Only seeing there is no calcium in coronaries, that gives you some assurance that
we call it triple rule out CT. In fact, last newsletter we have given a paper on that. Newsletter of Ccdsicon, if I remember, if I sir would remember. Triple rule out CT of a patient coming with chest pain, who is non-diagnostic. We are not able to make a head and tail of it.
Thank you, Ajay. Doctor. Thank you, Dr. Bhatt. No more time. Please, we have to conclude.
Thank you, sir.
Thank you, sir. Thank you.
Now we are going to invite our next speaker, Dr. Kunal Kishore. He is going to talk on X-ray in cardiology. Just invite.
Our next topic is very interesting. X-ray on cardiology by Dr. Kunal Shekhar, Faridabad.
Hello.
Good morning, everyone. So, 2 years back came this editorial, that's the scope, celebration of cremation after 200 years. This created a furor. Why? A leading cardiologist, Professor Jagat Narula from United States, he commented that the stethoscope is dead and the time has gone. William Conrad Longton in 1895 discovered X-rays. He said, I didn't think I investigated. It seemed at first a new kind of invisible light. There is much to do and I am very, very busy. It has been nearly 120 years and we have much more imaging modalities than X-rays which have come up. So, is X-ray going to suffer the same fate as our stethoscope? Are we here to pay an obituary to the cardiac X-ray? Let's go on in this wonderful journey. I, Dr. Shekhar Kunal, an assistant professor in the Department of Cardiology, ESI Medical College, Faridabad, take you on the next 20 minutes in cardiac X-rays in the 21st century. It is still relevant. I have no conflicts of interest to disclose, and I am not a radiologist. I am an interventional cardiologist with special interest in cardiac imaging. So if you see the spectrum of cardiac imaging, on the left side we have chest X-ray, which is all the basic. We have an echocardiogram, we have a static CT and cardiac MR, and a nuclear and SPECT and SPECT imaging modality. So I would like to take you through 5 cases. Those cases might seem unique, might seem you might not encounter in your clinical practice, but those cases were guided by the basic principles of X-ray when we established the diagnosis. First case, this takes me back 12-13 years back when I was doing a residency in my pulmonary critical care medicine. So she was an 18-year-old female. She presented to the outpatient department with episodic wheezing and dry cough. Now she has been labeled as asthma, has been started on inhaled steroids and bronchodilators, out with no relief. Now she had been taking this for past 1 year. Multiple physicians she had visited, no symptomatic relief. So we just reviewed investigations done previously. So this was the X-ray she was carrying. I took this case to my head of department. I presented him. And I said, sir, everything is fine. The X-ray, the PF, everything looks fine. Still, she has some amount of wheeze and she's very symptomatic. He said, you have not reviewed the X properly. You have not read Benjamin Felston. That's basically the Bible of X-rays. So what did I miss? I missed something in the right paracardial region. This was the curvilinear opacity, which was across the right paracardial region. That is called as a scimitar shine. That's actually a scimitar vein. So he said that, get a CT angio. We did a CT angio. We saw that there was a hypoplastic right lower lobe, and there was a vein which was draining into the IVC. Actually, the two pulmonary veins, the three pulmonary veins were draining into the IVC, and that was the case of partial anomalous pulmonary connection with hypoplastic right lower lobe. A diagnosis of scimitar syndrome was established, sent to a CTVS surgeon, operated, and the patient is doing wonderfully well. So, first case, we missed the important sign on X-ray, which could have established the diagnosis 3-4 years back. Again, another case, 30-year-old primary gravida presents sudden onset right-sided chest pain, 4 days following a cesarean section. She has been tachypneic for the past few hours. She has been on asthmatic, inhaled medications she has been taking throughout the pregnancy. Vitals, slight tachycardia, blood pressure again 98/64, with examination mostly being normal. And cardiac consultation was sought because the hemodynamics were a bit fluctuating. Again, we reviewed the investigations, basic investigation, X-ray, ECG, slight tachycardia, nothing specific on ECGs, and X-ray. Important clinical signs again. Two important signs which we picked up. First was the Pala sign, that is the right central pulmonary artery which is descending down. I think the point is not working. So this was the prominent right pulmonary artery, and she has on the right mid-zone a Westermarck sign that is related to oligemia. That is, blood flow in the right mid-zone was less as compared to the left mid-zone. Again, two classical signs of pulmonary embolism. We did a CT pulmonary angiogram. We had an embolus in the interlobar branches. We did a compression ultrasound right lower limb. We had a clot, and also the CT venogram confirmed that both the IGVs were having a clot. So again, a diagnosis was established. Third case. This is a very interesting case. Again, a 16-year-old male. He has sinuses since birth. Presents with hemoptysis, multiple episodes. Has been taking ATD, 4-5 times, unnumbered times. That's what in the periphery, most of them start consulting by doctors. He went to another center, a diagnosis of TGA. That's transfusion of great artery. That means aorta and pulmonary artery, where aorta was arising from the right ventricle and the pulmonary artery was arising from the left ventricle. What's the problem then? Let's look at the X-ray. By any chance, this X-ray looks like that of a TGA? No. If you see the TGA X-ray, you have got an agonal side appearance. On the left side, we have this X-ray, what we call it as the differential vascularity. On the right lung, you can see this pulmonary plethora. On the left, there's pulmonary oligemia. First. Second, what you can see is the pulmonary bay. That is just below the aortic knob. You can see a quite prominent pulmonary bay. That means the pulmonary artery was missing on the left side. Is it so? Is it the right diagnosis? What do we do? We went ahead, we did a CT aortogram. Because the X-ray was not looking like a TGA. So we wanted to confirm it. What we can see is the left pulmonary artery is arising from the RV, the right pulmonary artery is arising from the aorta. So that is a case of an abnormal origin of pulmonary artery. Only two differential diagnoses exist for differential pulmonary vascularity. One is aorta, which is also called hemitrungus. The another differential diagnosis is an absent pulmonary artery. Remember absent pulmonary artery? So that was the diagnosis of an aorta. Why a misdiagnosis? He has been made a diagnosis of TGA. TGA is something which is operable very early. At the age of 5, multiple echoes were done. Same diagnosis was continued. If you see the basic diagram I have made, LV is giving rise to aorta, from that RPA is coming. Normally when we do an echo, how do we make a diagnosis of pulmonary artery in echo? By means of bifurcation. Here aorta was itself bifurcating into right pulmonary artery and aorta. So everyone thought that this aorta was actually pulmonary artery, which is arising from LV, and from RV we have a direct branch which is going to the left pulmonary artery. That was thought to be aorta. And so they made a diagnosis of TGA. Now the point comes, did X-ray establish the diagnosis of hemitrungus? No, it gave us a clue. I would say no. It gave us the right path that we need to look. We need to reassess this patient. Did it bring a change in treatment? Yes. TGA is a very early operable as compared to doing a IOPA, which is having a icing migration and patient was labeled inoperable, was referred to as heart-lung transplant. Fourth case, young male with chest pain. Again, 28-year-old male, no previous risk factors. You are having persistent left-sided chest pain, sometimes on the right side also. Underwent a coronary angiogram, transfemoral, came out to be normal. 15-20 days, again he has a pain now in the right upper limb, which is radiating and some discoloration in his fingers. This was his upper limb, and we have an X-ray. Does something appear unusual? We said no. Again we made a careful look at the X-ray. What we can see is the bilateral cervical rib. Now that was explaining his chest pain, that was explaining the pain on the upper limb. Got a CT done, what you can see is a tunnel. Between the clavicle and the first rib, we have an extra cervical rib, and your subclavian artery is getting sandwiched in between the two. And actually the nerves and the subclavian artery which was getting sandwiched, while he was working, he was having pain and he was having discoloration. So he went for a surgical excision. This was the pre-op and the post-op. And the last case, this is the crazy case of hemoptysis. 20-year-old male. He was diagnosed with a case of VSD with Eisenmenger. Had multiple hemoptysis, multiple ATDs for 2 years. Pulmonologist referred him for an echocardiogram. We did an echo. We said that okay, it's a VSD Eisenmenger. Can have hemoptysis. VSD Eisenmengers are known to have hemoptysis because this pulmonary artery thrombus. But then let's look at the chest radiograph. This was the chest radiograph. Again, by and large, we didn't see some opacities on the left side, but what we missed was this. This is called rib notching. Here a classical inferior rib notching. VSD Eisenmenger is not reported in literature cause VSD rib notching. Then what was the problem then? So first we went, did a CT. What we saw was, there was prominent intercostals. So it's called the rib notching. So we made the diagnosis, okay, rib notching is because of intercostals. Now why intercostals are getting prominent? Here was the clue. From the intercostals, few arteries are digging. From this was the artery, that is a subpleural. These vessels which are going to the pulmonary parenchyma. And this is called as pulmonary neovascularity. Then because of Eisenmenger, the pulmonary blood flow was so much reduced that the body made up a compensation from the intercostals to the lung parenchyma. These neovascular vessels were bleeding. And this was a concept which was proposed in 2011. Only one case has been previously reported. So this case was recently accepted in the thorax, and we gave a new concept of pulmonary neovascularity in Eisenmenger, and that is causing his hemoptysis, and that is explaining the rib notching. So we didn't have any, X-rays, basic X-rays. Rib notching is not very unique. But just speaking of those principles, we made a very good established diagnosis. So let's come on to the current applications of chest X-rays. We are dealing with both adult and pediatric population. Pediatric because of paucity of time or not be covering. Adult, I was just saying, chest pain, dyspnea, post-interventional cardiac critical care. So the fourth spectrum what we have been covering up. Chest pain. Rather than ruling, it rules out everything. Rule out pneumothorax, fracture rib, pneumonia, and entities like rupture aneurysm, aortic dissections, pulmonary embolism, and few complications also. Like this, again, post-CABG, chest pain. Most of the time you think go get a CT coronary angiogram done. Just look at the X-ray. Upper 4 ribs, all were fractured. So that was basically a pain which was caused because of fractured ribs. This one, left-sided chest pain, comes to the casualty, acute onset. You have a ECG which has low voltages on the left side. Again, this is a case of pneumothorax. Right-sided tension pneumothorax. Right-sided chest pain, again because of crank consolidation and pneumonia. This was aortic dissection and aortic rupture. So when we do aortic dissection, there are few radiographic findings like widening of the mediastinum, wide aortic contour, tracheal deviation. But one sign is very common, is calcium sign. The intimal calcium is being split more than 10 mm. Normal X-ray doesn't rule out dissection. So just on basis of doing an X-ray, you cannot rule out dissection. Because the sensitivity is just 64%, specificity is quite good, 86%. So this is what I was calling as split calcium sign. You can see the aortic knuckle and you can see a calcium stripe. The distance between them is more than 10 mm. So that is one of the signs for aortic dissection. So this was the 32-year-old male, chest pain. Again came to us. What we saw was rib notching. Again, not very uncommon. Rib notching is very common. So we thought that, okay, let's do an echo. It won't be either a coarctation of aorta. We found out that, okay, we made a diagnosis of interrupted aortic arch. But luckily the patient also had chest pain. The patient was pain because of aortic dissection. So this was the aortic dissection. We had reported it 2 years back. That was the case of interrupted aorta with aortic dissection, type aortic dissection. Again, there was only second case worldwide reported. So that was just picked up on the basis of an X-ray with the rib notching. In the guidelines, the recent ACCH guidelines in 2021 says that chest X-ray can be done, should not delay urgent revascularization if indicated. X-ray in acute chest pain, assess the heart size, pulmonary congestion, identify potential cause. But by and large, it rules out the other causes. So that is the only utility of X-ray. In dyspnea, X-ray again, try to rule out other causes like heart failure. The X-ray sign, the first sign will be an antler sign where we have a cephalization. You can see the upper zones. You have a very prominent vessels which are going up. That's the antler sign. Then you have the curly A lines, the curly B and the curly C. The curly A lines are the parahilar lines, the orange lines. The curly B lines are the lines which are the green, and the curly C lines which are more towards the upper zones. So the curly lines. Then you have the battling appearance. And finally you can have a pseudo-tumor appearance on an X-ray which shows heart failure. You can differentiate cardiogenic versus non-cardiogenic edema just on the basis of X-ray. The only dictum is if the heart size is enlarged, it goes in favor of cardiogenic. And you have good peribronchial coughing in patients of cardiogenic edema. Pleural effusions are common in cardiogenic pulmonary edema. So on the left side you have very good, again a battering, on the right side also you have battering, but effusions are more common on the left side. You have fluid in the fissures, so left side is that of cardiogenic pulmonary edema. There is also an entity called unilateral pulmonary edema. 2% of patients of pulmonary edema will have unilateral. The most common differential diagnosis is severe MR, because the MR jet goes on to the right side. Positioning, re-expansion pulmonary edema or other differential diagnosis. So this was the pre-PCI. Patient had severe MR and inferior wall MI. Culprit was left circumflex. We did a PCI, and that was post-PCI. The MR jet regressed, and you can see the X-ray. So unilateral pulmonary edema. Valvular heart disease, tradition speaking, you have straightening of left heart border in patients with mitral stenosis, you have a widening carinal angle, you have a double lateral shadow. Then you have sometimes a giant LA, and an unusual LA can also develop. Patient might have Horner syndrome. We did a aortogram, we did a basically esophagogram, and you can see markedly dysphagia and as well as hoarseness of voice. MS and MR, you can differentiate to some extent on an X-ray. MS, the cardiac size will be less as compared to that of pure MR where you have a large cardiac size. Pericardial diseases, again, less than 200 ml effusion will not be visible. Cardiac silhouette enlargement is one of the visible signs. You can have enlarged pericardium. You can have pericardial calcification called as armored heart. One thing I would say, DCMP versus pericardial effusion. Does X-ray help? Yes. In DCMP patients, you have much more wider carinal angle because the LA is markedly enlarged. Lung congestion is there, it is favoring DCMP. Lung congestion is pericardial effusion, and you can see the cardiophrenic angles, which are basically more acute in pericardial effusion. So you can see on the right side, the acute right cardiophrenic angle is quite acute. That's basically a case of pericardial effusion. In critical care, you can find pulmonary embolism, the sensitivity is 33%. We can have various signs such as the Fleschner sign, enlarged bilateral pulmonary artery. Then you can have the Hampton's hump, then the right inferior region you can have a quite peripheral infarct. Pneumopericardium can be distinguished. In pneumopericardium versus pneumomediastinum, in pneumomediastinum the air tracks around red vessels. So if the air is present above the region of the aortic knuckle, you have a pneumomediastinum as compared to pneumopericardium. Central venous catheters placement will be helpful. Post-intervention, just few slides. You have sometimes a patient comes with pacing loss and you have a pacemaker landed up directly into the pocket. The leads are into the pocket. Sometimes the lead perforates and goes below the diaphragm. Then you do a CT and confirm lead is gone. Sometimes you have a lead fracture below the clavicle. So X-rays can pick up. The way ahead, AI is going to rule the world. So we have just a presentation in the RSNA 2022. They said that we can have a 10-year risk model. That is a CXR CDD model using 40,000 patients data. And what we have shown is that chest X-ray is more than that of chest X-ray. With an approach like this, we can get a quantitative measure which allows to provide both diagnostic and prognostic information. So X-ray is just not related to just only X-ray. X-ray is going to be transformed because of artificial intelligence. Advantages, it's very easy, simplicity, portability, anywhere you can do it. You can take an X-ray to your ICUs. You can take a CT and MR machine to your ICU. Limitations, again two-dimensional modality. You cannot compare with MR and CT. So it's just like a David versus Goliath. So if you know David which is fighting with the Goliath, need for multiple views. Single view is not always confirmatory, you need multiple views. Technical parameters, you require underexposed, poor infiltration, so training is very important. And pregnancy again contraindication. Radiographs can be misleading. So this is a very interesting X-ray. Right lower zone consolidation. Chest physician does the bronchoscopy, couldn't find anything. A CT was done, and you see a Rasmussen's aneurysm which was partially ruptured. We did a device closer for that. So if you have X-ray, only an X-ray won't help. X-ray will be a guiding source. In conclusion, X-rays are relevant. They find a place in the current clinical practice. Good screening tool, especially for acute chest pain and dyspnea, to rule out non-cardiac causes. Great guide, definite workup. Good team person, not a solo performance. Thank you for patiently listening.
Thank you, Dr. Krishna, for excellent presentation. I think we must admit, the first view X-ray he showed to us also, it appears normal. But if mind does not know, eyes cannot see. Certain things were there which we were not, we could not have diagnosed. But the CT and other things help. So, but other X-ray, he has very well said, DCMP, petrocalcium fusion, cardiomegaly due to valvular heart disease, these are the very common. And still, X-ray, as I told you, ECG, the two basic investigations, ECG, X-ray, they have been not replaced by modern investigations. Still they have got place in there.
Sir, I must add one thing. In all cases of heart disease, the lungs must be examined, and in all cases of lung disease, the heart must be examined. This is the rule. Thank you.
Thanks, Dr. Kunal, for your nice presentation. Still, X-ray and ECG is the basic tools for the diagnosing the case, and it is available every place. Many thanks.
Any question from the audience?
Question to
Hello. Any comment?
Yes. Excellent presentation, and I must say I can go anywhere in the world to hear you again and again. One clinical question. You used X-ray and CT, so it is not a good time to miss USG. So I put a clinical question to you. Suppose a patient who is pregnant comes to you with acute onset shortness of breath. Does USG help you to differentiate whether it is cardiac or not non-cardiac? Not absolutely, but can it help you?
Thank you, Sumit, for this question. This is a very pertinent thought. And we have a point of care ultrasound, what's called a POCUS. Now, POCUS has this important application, especially in pregnant patients, where, an X-ray cannot be possible to some extent. So if you have some B lines, you're seeing in a POCUS, to some extent you can say, okay, it's basically the cardiogenic cause, especially cardiogenic pulmonary edema. More control with the B lines, more effusion, you can scan for the effusion. If the effusion is present, if you have a B line, you can say, okay, it's something related to the cardiac cause.
Thank you. That means B lines is important in USG. We can also use it follow case of heart failure, whether it is actually an early sign for deterioration of patient of heart failure. Like just we can see that if a patient of heart failure has repeated atrial fibrillation, infection, it can deteriorate. In the same way, if you do regular USG of that patient in follow-up, if there is an increase in B lines, that it will suggest that the patient will deteriorate in coming time. So it is the time you can start, you can increase your drug modalities. Thank you.
Thank you, organizing committee and Dr. Smith for the.
Please be seated here.
Thank you, sir. Thank you. Very nice talk. Very nice talk with the simple method. Third topic is very important. Which is going to be delivered by Dr. Ajay Kumar Singh, a well-known cardiologist and very close to us.
Ajay Kumar Sinha from Medanta. Medanta Hospital, Patna. I think everybody knows Dr. Ajay Kumar. He is well known, and he is going to discuss one of the commonest arrhythmia. It is said to be benign, but always I will tell you it is the commonest, and if you do not diagnose and manage properly, the patient will have critical thromboembolic complications. So diagnosis of management of this commonest arrhythmia which we get nowadays, it is occurring, it is detected more and more because it occurs elderly even without underlying cardiac pathology. So I would request Dr. Ajay Kumar to present his talk.
Good morning still. Sorry, good afternoon now. So, thank you, sir. All the chairs. Abhay, after a long time we are talking to each other and you were too fiery. Must tell you that your talk was absolutely fiery, very splendid, full of knowledge. So really, we appreciate that. So let me start with the ECG. ECG we just put. I thought now my topic is not having a single ECG. That's bad. So why not have quickly? I took some ECG from somewhere and put it here. In our undergraduate days, UG days,
we talked. We were given a lesson that if you have irregularly irregular heart, that is the clinical hallmark of atrial fibrillation. But we have three differential diagnoses: atrial fibrillation, atrial flutter, and multifocal atrial tachycardia, which is again a very common entity in COPD patients. Now, another simple ECG, which Dr. Rai loves that ECG, a 25-year-old male brought with severe hypotension, past history of palpitation, given some drug somewhere. So what is the solution? What is the solution out of these four? I think if you have hemodynamic compromise with atrial fibrillation with fast rate, the answer is cardioversion. Dr. Abhay, am I right?
Yes. If you do not know, every node do not be blocked.
And such patients are going to turn into, when they are in sinus, you will see a pathway, you may see a pathway, and then answer is radiofrequency ablation. So that is the lesson. Again a patient, 85-year-old male. Again I love seeing this, showing this ECG again and again, because this is a learning experience for all of us. Normal heart, normal LV function. So what do? What is the choice? See, this is the learning point that antiplatelets do not have a role in atrial fibrillation management. This mistake is time and again done. Somebody will give aspirin, somebody will give dual antiplatelet, but answer is not that. 85-year-old male, the answer is oral anticoagulant. Now again, fourth caveat is, fourth phenotype of atrial fibrillation is when RR interval becomes absolutely fixed. And this is complete heart block. So with this background, I will take you to a journey of another 10-12 minutes. The rate or rhythm control in atrial fibrillation. Still, I feel that debate still continues. So I bring greetings from hospital where I work. I take my salary, so I must show some slides showing Vedanta hospital greetings. So let's see what happens in 99. We had, you see, this is the map of America. Map of America showing number of atrial fibrillations. So how it has increased in last, say, just 14-15 years, the number of cases have increased like anything. And why so? Because of so many cardiovascular risk factors, aging of course, aging is important, obesity and all those factors. See, this is the scenario. The red one is the highest incidence. And we, the low incidence is still less than 600. And the middle ones are the China and such countries. They have a middle kind of incidence. But the very important thing is to know that all of us should understand that 3 out of 1 will stands a lifetime risk of having atrial fibrillation. Another important fact I wanted to highlight is that if you have somebody has atrial fibrillation, there are chances of having atrial fibrillation in the family. That is extremely important, and this was highlighted in Framingham study. What is important about atrial fibrillation is
that cardioembolic stroke may happen, will happen, and about 25%, 1/4 of atrial fibrillation is because of atrial fibrillation. I'm not going to read out all this in great detail because all of us are knowing this. I'll just take you to a story that currently Douglas Zipe has presented a nice presentation in ACC 23, and this is a worth listening. You must go and listen to him, what he has spoken about atrial fibrillation. Another, encounter in one of the API meetings, me with great people in atrial fibrillation across the world. My presentation in 2012 at ESC about atrial fibrillation, and those days were days of only rate control. And still, I believe in our country, the answer is rate control. And if you see, there are the 3 guidelines or hallmarks of managing atrial fibrillation: ABC, and anticoagulation, rate control or rhythm control, and finally taking care of all those cardiovascular risk factors. Can I have water? Sit it with the water. Yeah. Now, this is the year 2012, when the IHRS, our own society, which was very nascent, Indian Heart Rhythm Society, they published their paper on atrial fibrillation, and in those days, this majority of them were rate control only. So rate control was the answer, but mind you, the main focus of today's electrophysiologist and cardiologist and physician is on left atrium. That the focus is on left atrium. If you do not treat all those factors which are leading to atrial fibrillation, you fail in your duties, you fail in your approach. This is again focusing on the role of left atrium in atrial fibrillation, and structural remodeling which happens in left atrium, and electrophysiological remodeling which takes place first. First you have electrical remodeling, and that is the time to attack. That is the time to treat atrial fibrillation. Once you have structural remodeling, it's very difficult to revert this arrhythmia. Guidelines are not lifelines, but guidelines will tell you what is the role of radiofrequency ablation. If you have paroxysmal atrial fibrillation, which is not being controlled with drugs, if you have a persistent atrial fibrillation in early time, less than say 1 year, and if you are not being controlled with drugs, you think about radiofrequency ablation, and guidelines are also telling us that. But the problem is what? Problem is serious side effects of drugs which we are giving. Be it even the current drugs like dofetilide and flecainide, we have a lot of side effects. So we have to be aware of that. I give you a question, a case history, brief case history. 6-year-old male physician with several years of history of symptomatic paroxysmal atrial fibrillation. Paroxysmal atrial fibrillation, poor exercise tolerance during episodes of atrial fibrillation, daily episode increasing in frequency and duration, well-controlled diabetes, CHATS fast score. So what is the answer? Would you like, echocardiogram is normal, would you like to subject this patient to catheter ablation? I'll come to this point. The first study, Stop Atrial Fibrillation, which gave us a lot of encouragement to use radiofrequency ablation in managing atrial fibrillation, and compared with drug, there was a drastic difference if you see the graph. Again, recent days, cryoablation has come in a big way. About few weeks back, one of my patients who got ablation done at Delhi, Dalveer Singh, who is a famous cardiologist at Delhi, he was asking me, Ajay, what to do? Should I go for conventional? Should I go for cryoablation, which will be slightly costlier, but very useful, less of complication. So cryoablation has come to our country, Narsimhan and all. There are several centers which are doing now cryoablation. Now, another few things, why I am highlighting that unless we know what is the advantage of newer cars, we will still depend on ambassador, old ambassador, as happened in Calcutta. Ambassador used to ride, people used to ride ambassador car in Calcutta for a pretty long time. Now we start seeing all those modern things. Pulse field ablation, which is a modern technique of doing radio frequency, not ablation, because it saves the tissue and the media around the cell. And this is going to change the scenario of radio frequency ablation in atrial fibrillation. Another big advantage is that RF ablation decreases the progression to persistent atrial fibrillation. That's very important. So now I am speaking in favor of only radio frequency ablation. Another trial which has clearly shown that, a test trial, again it showed clearly that if you use radio frequency ablation, you are going to have less incidence of progression to a persistent ablation. And you see this slide clearly shows that there are nth reasons, nth number of reasons to use radio frequency ablation in atrial fibrillation, because you are managing the anatomy as well as the physiology of atrial fibrillation. Large studies have definitely shown lower risk of stroke and mortality with radio frequency ablation. And another very important thing is now decline in cognitive function. You see, all the AF patients who are on your drug, they will have slowly decline of cognitive function, and then this becomes very difficult because they go in the hands of psychiatrists and they have lots of problems. So cognitive decline can be prevented by using early ablation. But is rhythm control good enough to maintain a sinus rhythm, to eradicate symptoms, to eliminate adverse outcome? You see the first trial which came, CAST trial. We divide our study on atrial fibrillation in two groups, pre-CAST trial and post-CAST trial. If you see the before the CAST or CAST trial, did not show any advantage of ablation compared to rate control. Again, this trial again shows a similar criteria, similar atrial fibrillation in heart failure. Again, this was same. But if you see, from 2014-15 onward, we had several studies because our technology improved. We started using newer technique. We had newer devices, cryoablation. So we started thinking in better way. So we realized that probably ablation is going to change the scenario. But then one important trial which came is known as East AFNet 4 trial, which changed the scenario of our thought, which changed our thought process. Because they say that even with drugs, if you are trying to convert into sinus rhythm, the outcome is much better. And this trial was done in a very recent trial, and this has changed our scenario. Early AF trial, again you see, Cabana trial, which was done with lot of enthusiasm, did not change our thought. They did not encourage us, and Cabana trial gave us the idea that probably radio frequency ablation is not going to change the scenario very much, although there are many contradictions. RAF trial, and the long-standing outcome of ablation has given us a thought that probably ablation is better than drugs only. Again, this is a real-world study of about 2 lakh patients, which clearly showed that probably ablation could do better. But then this is a very important slide which clearly showed that there are so many caveats, so many phenotypes which has to be tackled from the beginning. If you really want to handle atrial fibrillation, there are factors, several factors which should be handled nicely to give a very good result. This is a new trial known as the ABC approach, which clearly started showing light on rhythm control. Rhythm control alone good enough only in some patients. Risk remains even with rhythm control. Even if you are given a sinus rhythm, the risk will remain same. So this is very important. And management of atrial fibrillation requires looking at the patient in totality. In totality, rather than just doing a radio frequency ablation. And these are the 4 pillars of AF management. See, these 4 pillars all of us know. But then a recent article in JACC came which gave us a light. Which are the caveats which are going to be helped by radio frequency ablation. So AF ablation, miracle or myth, don't know. Don't know. In our country, still we are depending more on rate control, but we are coming up with larger number of centers which are doing radio frequency ablation of atrial fibrillation. But then, if you see this biobank, this is a biobank study from UK. They had a huge population. They studied and they found out that about 50% patients of atrial fibrillation, they had inflammatory markers. So now the new player has come. That you take care of inflammation and you take care of atrial fibrillation. That's what the concept is. And then towards the end, I would say that we have a Medanta conclave on 15th and 16th. Anybody, you are most welcome to attend that. And this is an integrated approach of management of atrial fibrillation, which includes everybody, physiotherapists to physician, to cardiologist, and this to family care. And this is a caveat of gamut of all those people who are. But I would say in my final conclusion that we are still improving. We will be learning till the end of our career, and this was told by not less than the Olympic gold medalist and silver medalist. Thank you very much.
Thank you, Dr. Ajay Kumar, for excellent presentation. I think he has very well said, the rhythm control stage is not enough. I think if you have opportunity for radio frequency ablation, I think ablation, no doubt is a gold, but it's not available everywhere. But at least radio frequency ablation. But I don't know whether it's available at Patna or not.
No, cryo is not available. Cryo is not.
Radio frequency ablation?
Radio frequency ablation people are doing, but not
yet. So still we have to send the patient to Delhi or Calcutta for radio frequency ablation. But still, so with this, I request our chairperson to invite question and do some comment.
If any question from audience, please.
Hi sir, I am Dr. Harnish from Delhi. I want to ask a very simple question. We have known that ablation probably does not reduce mortality as various trials have shown. But there is enough data to also say that a persistent AF, even though rate controlled, will lead to some sort of atrial and ventricular remodeling over the time, and that will lead to worsened prognosis. So in considering all of those things, I say if a patient who is a 64-year-old gentleman, hypertensive, comes with a new onset AF, documented sinus rhythm before this episode, symptoms say for 24 hours, it's a lone AF, echocardiography is normal. How to go about this patient? Since we also know that lone AF is very well known. Okay, yeah. I'll probably hold it closer to me now. So I'm saying, considering the entire picture, that ablation has not really shown to improve mortality, but it definitely reduces remodeling, and over the course, remodeling does lead to a bad prognosis. So what I want to say is, if a 64-year-old gentleman comes who is a known hypertensive and is found to have a lone AF, new onset, we very well know that lone AFs are known to convert to sinus rhythm on their own a lot of times. So how early would you want to intervene on this patient with an ablation procedure? And how long do you want to give the trial of medical therapy? Say you will put him on beta blocker, right? That's what all of us do, or a calcium channel blocker. But how longer do you want to wait? 1 month, 2 months, 6 months before you actually send the patient for ablation?
There is no fixed guidelines. If you have a recurrent atrial fibrillation, firstly paroxysmal. If you have recurrent paroxysmal atrial fibrillation, which is troubling you and you are symptomatic despite drugs, I think you should go for radiofrequency ablation. There is no doubt about this caveat. If you are having a persistent atrial fibrillation in first 3 months, if you take a 1 year span, and first 3 months you must try to revert into sinus rhythm. And this will give you a very good result. And beyond 1 year, I think there is no point trying radiofrequency ablation.
Sir, would I just make a comment? We have been doing RF ablation for the past 2-3 years at our center. We are facing 3 important issues. First issue is that a majority of them are having a rheumatic AF. They have a permanent AF. Early detection is always the key. Whenever we have a paroxysmal AF, those have been shown to have a very good response. Secondly, heart failure is the only aspect. Currently, all of the trials have shown, even if you have the aspect of Kamana trial, the heart failure subset is the patient more going to benefit rather than having an absolutely mortality benefit. And third thing is that there is no consensus on anticoagulation even after RF ablation. When 3 months, 6 months or a year, because patients might have having episodes of intermittent AF despite doing a complete pulmonary vein isolation. So these are the 3 things which I feel has been the point.
Sir, excellent presentation, sir. And it is a great honor for all of us to hear you in this hall. Regarding final management of AF, the debate will continue whether to go for rate control or rhythm control. I can say, if suppose 2 patients are there, both are of heart failure, and we have started on rate control, one is asymptomatic and another is symptomatic. So, in the management of AF for all, it should be individualized. If a patient of heart failure on AF management, rate is controlled. If he is asymptomatic, then we can proceed with the same treatment. And if that patient is symptomatic, despite of rate control, definitely we should go for the cardio version, whether pharmacological, RF ablation, cryo ablation. But the limitation of RF ablation, as Dr. Kunal Shekhar said, that there may be the foci may be endocardial, maybe myocardial, epicardial. So whether to go for endocardial ablation, epicardial or hybrid. So these are the limitations for the success of complete resolution of atrial fibrillation. Thank you, sir.
Thank you. Now I think we should conclude it because we have got busy program. After the presentation, we are going to have the release of our e-bulletin. So with this we conclude. Thank you, Dr. Ajay.
Thank you, sir. Thank you, moderator, sir, all the speakers and the chairperson, sir. Now the chairpersons will honor our speakers. First of all, I would like to request Dr. S.K. Goenka, sir, to honor Dr. D.P. Khaitan, sir, with momentum. Dr. Goenka, sir, to Dr. D.P. Khaitan. Dr. Ashok Kumar Gupta will honor Dr. Abhay Krishna. Dr. N.K. Nawal, sir, will honor Dr. Kunal Shekhar. Dr. Priyaranjan will give memento to Dr. Ajay Sinha sir. Now I would like to request moderator Dr. Professor N. Rai sir to give honors to all the chairpersons. Dr. S.K. Goenka, Dr. Ashok Kumar Gupta, Dr. N.K. Nawal, Dr. Priyaranjan, to Dr. Priyaranjan. Now I would like to request Chairman of the State Chapter Dr. P.K. Singh sir to please come on the dais and honor our respected moderator and founder president Dr. Professor A. and I. Dr. P.K. Singh sir to honor Dr. Professor A. and I sir. Now, in just 5 to 10 minutes, we are going to release the CCDSI e-bulletin, and for which I would like to request our founder president, Dr. Professor N. Rai sir, our national president, Dr. A.K. Virmani sir, editor of the newsletter, Dr. Ajay Sinha sir, chairman of the state chapter, Dr. P.K. Singh sir, and the section editor, Dr. K.K. Lohani sir, to please come on the dais. Dr. Lohani sir, please. Dr. Lohani sir. First of all, I would like to request Founder President Dr. A. sir to give blessings to the team who used to do this tremendous work of just compiling the newsletter every 3 to 4 months, and which is going to be released today. Dr. A. sir, your words of blessings. Sir, I request you to give words of blessings to the team, editorial team.
We are here to release the e-bulletin, and this concept of e-bulletin was brought by none other than our former President D.P. Khaitan. Initially, we decided to publish a journal, but due to some problem, it could not be published. Then it was decided to have a quarterly e-bulletin of the CCDSI. And since last 2 years, we are having this e-bulletin. Our first, this quarterly bulletin, the first volume is on cardiology, second is on hypertension, third is on diabetes, and last is nephrology. This is going on. So for this session, we are going to release the first bulletin on e-bulletin on cardiology. And this has been, the editor of this bulletin is Dr. Ajay Kumar, and associate editor is Dr. Vikas Singh and Dr. Lohani. We have got an editorial team, and this editorial team has got editor Dr. Ajay Kumar Sinha and associate editor Dr. K.K. Lohani and Dr. Rajkamal Chaudhary. He is not there. So I must compliment the team, especially Dr. Ajay Kumar, but for bringing this bulletin in such a short time. This bulletin can have interesting clinical cases. The theme of this bulletin was to have, we should publish the cases which has given some lesson to the clinician. So this bulletin is very important, and if you go through this actually, this contains, it is not a literature. This has got the interesting clinical cases, and which has changed the vision of the clinician. That was the theme. So with this, I once again thanks Dr. Ajay Kumar Sinha and his team.
Now, President sir, please few words. Dr. Virmani.
Professor A.N. Rai, Founder President, Dr. P.K. Singh, Organizing Chairman, Dr. Lohani, and Dr. Ajit Sinha. It is a pleasure for me to be here today in the release of the e-bulletin, which has now become an integral part of CCDSI. And we have been releasing it in the last 2 years. And Dr. Ajay Sinha and Dr. Lohani have really worked hard for this bulletin, and I'm sure you will find it a lot of interesting and helpful to learn new messages from the clinical cases that they have reported. With this, I wish all a huge success.
अजय सिन्हा सर, आपकी मेहनत हमेशा रंग लाती है। आपके श्रीमुख से हम लोग कुछ सुनना चाहते हैं कि इस न्यूज़ बुलेटिन का क्या इम्पोर्टेंस है हम लोग के क्लिनिकल फील्ड में।
Thank you. I must thank Professor A.N. Rai, Dr. Virmani, Dr. Pramod, Dr. Lohani. Without your help and without your vision, it was not possible to bring this newsletter. And I must not forget our good friend Mrityunjay, who has always been very and this time it is on cardiology, clinical cardiology, and the whole idea was to give a case report with some lesson at the end. So I invited people to give their cases, which has given them a learning sort of thing. And with this, we went ahead and we have come out with this newsletter. I hope in future you will encourage us and will give us your thoughts, your inputs, so that we can do better. Thank you.
Thank you, sir. Sir, please do the book release, the newsletter release. Okay, thank you, sir. Thanks to all.
One message. We have got 100 this book here available, and rest is available on a website. So those who want to have a physical, they can collect. I think distribution, please. So those who want to have, they can have this. Otherwise, we are having this e-bulletin on our website. Thank you.
Thank you, sir, for this book release. Now we are moving towards the third session, and for this session, the moderator is Dr. R.R. Chaudhary, sir. Sir is the retired professor and HOD of Medicine, PMCS Patna. Sir, please take your seat and proceed further.
Thank you, Dr. Abhishek. Good afternoon, everybody. At the outset, I would like to thank the organizers, particularly Dr. Sumit and Dr. P.K. Singh, for inviting me for the role of moderator. I would also like to thank Dr. N. Rai and Dr. Abhishek for their continuous support and providing me the occasions. This is a session on diabetes related to diabetic complications and treatment. We are behind. I can say that we should have completed this session by 1 p.m. and now we are going to start it at 1 p.m. So, without losing time, I would like to call upon the chairpersons, Dr. N.C. Singhal from Jamshedpur, Dr. Shyam Narayan Prasad, Bihar Sharif, Dr. Shyam Narayan Prasad, Dr. Gagan Gunjan from Ranchi, and Dr. Deepak Kumar Singh from Bugusarai. There is slight revision in the speaker schedule. The first, Dr. K.K. Lohani from Gaya. Yes, sir. Yeah, you are chairperson. So there is a slight change in the schedule of speakers. Dr. Birmani has got some urgent work, so he has to leave. And so I request the President, National President of CCDSI, Dr. Birmani, to introduce and present this. Dr. Singhal.
Dr. Birmani probably needs no introduction, but still this is customary to introduce the speaker. We have been listening him since probably 1 decade or so, and he's a master in diabetes and a very good person. Please go on.
Thank you. Respected moderator, sir, and honorable chairpersons. At the outset, I would like to congratulate Dr. P.K. Singh, Dr. Sumit, Dr. Ajit Sinha, and the entire Bugusarai team for the wonderful arrangements. Now, we have been hearing, can you take this off and put my presentation on, please? Okay. So we have been hearing a lot of science since morning. But unfortunately, medicine is not only science, it is also art. And what I'll be talking about today is the art of medicine. Now, when we look at patients with diabetes, and this is what I'm going to talk about, diabetes distress, I would like to ask from this elite audience, how many of you understand this term or how many of you have ever labeled or put this diagnosis? Anyone? Are you aware of this term, diabetes distress? Anybody? Okay, anyway. Now, when we talk about diabetes distress and depression, they seem to appear to be same, but they are not. They are related, yet conceptually different. And how it is? If you look at depression, that is basically a mental health disorder which is twice as common in patients with diabetes. On the other hand, diabetes distress is basically an emotional response to living with diabetes, which is a life-threatening illness that requires chronic, demanding self-management. 30 to 40% of adults with diabetes are likely to report significant levels of diabetes distress. 30 to 40%, and yet majority of us never think about this or make a diagnosis. And it is an overlooked and consequential comorbidity. The burden of relentless daily self-management and the prospect of long-term complications has a very devastating effect on the emotional response of patients living with diabetes. The expected worries, concerns, fears, threats that are associated with struggling with a demanding and progressive disease and its management. So what do we know about diabetes distress? 20 to 40% in both type 1 and type 2, so it's relatively very common, does not disappear on its own without chronic intervention. And of those with high distress at baseline, at least 75% will come back after 9 months. Highly significant clinical impact related to the high A1C, missed medications, missed healthcare appointments, worse physical activity and diet, and lower quality of life. Higher distress among those who are younger, females, ethnic minorities, or experiencing adverse and determinants of health, complications, and various comorbidities. The more the comorbidities, the more the distress. It starts with denial, loneliness, low motivation, frustration, fear, and ultimately defeat. Who are at high risk of patients for diabetes distress? Women report more depressive symptoms and more diabetes distress than men. People who report symptoms of depression are likely to experience diabetes distress and vice versa. And this is because there is a very thin line between diabetes distress and depression. Younger, middle-aged adults are more likely to suffer. Severity of illness, hyperglycemia, complications are what that can lead to diabetes distress, and that itself can lead to poor glycemic control. Those who are on insulin are further likely to have diabetes distress, and the prevalence is higher in people with type 2 diabetes, but then we need more data because type 1 diabetes have not been studied that much as far as diabetes distress is concerned. So 1 in 5 people with type 2, 1 in 6 non-insulin dependent type 2, and 1 in 4 people in type 1. Now, there are varied manifestations, feeling of frustration, powerlessness, hopelessness, pronounced fear of hyperglycemia, complications, avoidance. They don't bother, oh, it's not me, I am not involved. They are in denial, they don't get the consequences. There is a burnout because of all the management tasks that they are told, self-management of diabetes. We want them to monitor their blood sugar regularly, the blood pressure, and take the medications or insulin at the right time. And that's why most of these patients have anger, frustration with providers. There is hostility. They don't show up for the appointments. So how it is expressed is going to vary from person to person depending on their personality. And it is going to increase if there is a diabetes-related event like hypoglycemia or change in the medication. Remember, the heaviest burdens that we carry are the thoughts in our head. And that we must always remember. So what are the sources? The management demands, hypoglycemia, fear around long-term health and complications, powerlessness, healthcare provider team may not react properly with the patient, family and friends, healthcare access, cost. Cost is a very big issue. Stigma of being a diabetic, shame. Oh, you are a diabetic because you are not taking a good lifestyle. That is what we are telling them. And what are the consequences? It is a barrier to good glycemic control. Constrains energy, reduces motivation and engagement, and reduces responsiveness to other interventions. And it is important that we intervene here to maximize clinical outcomes for some patients. Friends, keep calm. There is good news. And what is the good news? It is malleable, highly responsive to intervention, dramatic reductions can occur, benefits seen from a range of interventions, and addressing distress directly may be more effective. So how do we approach? The goal is to reduce powerlessness and regain a sense of personal control over diabetes. We make the patient the supreme commander of his disease. And the key is to emphasize to the patient, remember, you are not alone. It is not your fault. You are not a bad person. You are not struggling. Don't shame him. You are not doomed. And I and you, as a doctor or a healthcare provider and the patient, are a team which is going to treat this. And like everybody, it says that yes, we can do it. So addressing, how do you address these patients? There are 5 points. First, you must assess for diabetes distress, use relationship building tools, listen, develop a plan and follow up. Assess when, anytime, especially when you are changing medication, putting your insulin, or putting a CGM or you have hypoglycemia. What do you do? There are questionnaires. You ask the patient to answer those questionnaires, and there are certain items which are sources of high distress, and it is discussed and it is brought up in the conversation with the patient. For example, you may say, the patient has put, I like to eat a lot. So you ask the patient to start your conversation, you have written that this is the biggest problem, you are a binge eater. We'll solve it, no problem. Don't shame him for that. And how do we assess? There is a standardized validated course, screening assessment, and the most common is the DDS, and it has got the diabetes distress score, and has a 17-item score. I will not go into the details, it's available on the net, you can go through it. There are various points, and you can label the amount of diabetic distress. The second most important thing is to use relationship building tools to understand the distress. Be social, build trust, assist the patient to grow, and take a long-term view. Stand out from the crowd. It's very important because your authority is what is going to make the patient more powerful to disease, to fight with his disease. Don't be a fixer, be a listener. That's very important. Slow down, pace, tone, speed of speech, atmosphere of engaged and empathetic listening, clinical engagement tools and examples. You have to label feelings and belief. It's like you are frustrated, you are telling the patient, you're frustrated because of certain thing that happened in your life. Summarize and reflect. Okay, you are telling me these are your problems. So the patient understands that you are really want to help him. And normalize and tell the patient, don't worry, it is not only you. A lot of people, even I have felt like this at some times, whenever I've had a stress. Listen. Listening is very, very important. And look at the patient. The commands that the patient is giving, the gestures that the patient is making. And there are certain gestures, themes. Patient may say, I'm going to lose 20 years because of diabetes. Tell him, it is not correct. You can lead a normal life. I may get blind. No, if your blood sugar is well controlled, you cannot get blind. There's feeling of powerlessness, discouraged. Life is hopeless. I can't eat properly. Separate out the feelings from behavior, and I'll tell the patient nothing to worry. Remember, God has given us 2 ears and 1 mouth. So we should listen more than we talk. So first aim is listen and reflect. The second aim is gently address the issues that the patient has. Then develop a plan. And that plan has to be developed along with the patient. If there are financial problems, involve social services, NGOs. If there is a family problem, involve the spouse, close relative, friends, etc. Making a plan basically helps the patient to find one specific thing that they can do differently. Ask the patient to come up with a plan. Make sure the plan is simple and achievable. Short-term plans can be tried for a few days. Ultimately, follow up. And that is critical and tough to implement. Patient may not come back. So you encourage the patient to come back or follow up in an agreed time frame. Okay, I will see you after 20 days and I want to see how much you have improved. Work on that. Consider monitoring distress levels and keep on monitoring the same questionnaire. See how much, whether the score is coming down or not. For example, how do you feel about your sugar levels now? Last time you told me you're frustrated. Are you feeling better now? So these are the things that is going to help. And we need a lot of things are there, the policy, the organization, the community, the individual, and environment. I'm not going to go into details. They have a lot of influence on the patient as diabetic exists. But as individual clinicians, what should we be doing? Our goal is to give ongoing support to promote self-care, make the patient powerful. Use of organ protective drugs based on science and evidence today. Treat to multiple targets, be holistic in your approach. Get the blood sugar, the lipids, the blood pressure, all under control. So the patient comes, register what he has got. Risk assessment is very important. Risk stratification is very important. Review and risk factor control, and then relay, reinforce, and recall. And what we are doing is basically coordinated care and not uncoordinated care. And when you do coordinated care, you get an empowered patient with optimal control who's happy, and not an poorly informed patient with suboptimal control. Friends, diabetes distress is real. You need to recognize it in your day-to-day practice. And remember the famous quote by William Osler: "The good physician treats the disease, the great physician treats the patient who has the disease." Thank you for your patience.
Thank you, Dr. Bhumani, for a very unique and very useful talk on a subject which we usually ignore in our clinical practice. But just contrary to it, this is one problem which is reminded of every day to the patient of diabetes in his home, in his clinic, in the society, on television, everywhere. Right from the morning, the patient of diabetes sits on the dining table. His family members put beautiful and very delicious breakfast on the table, but reminds him that you are a diabetic. You are not supposed to eat it. Right from where this problem starts. So you open the net, whole day you will see you are suffering from diabetes. This is a bigger problem than the Ukraine war. All the time the patient is in distress. So you have addressed this issue very nicely. And I think if anybody has any query, this is the time you can ask Dr. Virmani. I think there is no question. So I hand over the mic to our moderator, Dr. R.R. Chaudhary.
Thank you, Dr. Virmani, for brilliant talk. In lighter vein, I would like to ask whether these patients should be sent to psychiatrist or the diabetologist will treat it.
No, sir. Psychiatrist, this is not a mental health disorder. If the patient is suffering from a depression, a severe depression, or a psychiatric illness, he needs psychiatric treatment. But if he is suffering from diabetes distress, it is our fault. Our personal rapport with the patient is not good, so we don't need the help of psychiatrists. We need to improve ourselves on how to deal with the patient.
So, yesterday was the World Health Day, and a pledge has been taken by all the diabetologists to eradicate the complication, to work for the eradication of the complication of diabetes. And I'm very glad that Dr. Virmani has said that all diabetic depression should be treated by the diabetologist itself. Thank you. Thank you.
Can I?
Ajay.
First, super duper. The talk was super duper. There's no doubt about it. Let's give a big hand for Dr. Virmani. And secondly, why not copy and paste your plan to our cardiology, nephrology, urology? I was sitting with one of the urology colleagues here. Because, every discipline has got the same problem, same distress, same depression. And, there's nothing. What I do in my clinical practice, in Medanta, I just empower them, that's all. I empower the patient and I empower the family. That's all I do. Because rest of the things are everybody is doing. Same medicine with Dr. Rai will write, I will write. But why Dr. Rai is better than me? Only because he has got that connection. He has connected to the family and he has connected to the patient. If you are connected to the patient, if you are connected to the family, you are done. I think this is a bigger responsibility for us, especially in our present society, than it was there some years back. Especially after COVID era, everybody is, frightened कि मेरा diabetes COVID के बाद बढ़ गया, मेरा angina COVID के बाद बढ़ गया, मेरे को heart attack COVID के बाद हुआ. तो ये चीजें जो है बहुत जरूरी है. So wonderful. Lot of compliments to you.
Thank you, sir. I think you are very right.
Just one, Dr. Virmani, just a very practical thing I want to ask you as a practicing physicians. If we really believe that the patient of diabetes is having a lot of anxiety or depression, which anxiolytic and which antidepressant is safe to prescribe?
See, if you are a good communicator with the patient, as I said, and as Dr. Ajay Sinha very rightly said, empower the patient, shared decision making. And if you do all this, you don't need drugs, antidepressants or anxiolytics at all. These are only, small sort of to bridge over a crisis. But most important is you must have a good communication with the patient, and patient must learn to trust you. No matter what happens, he'll come back to you again and again asking for your advice. And you don't need any antidepressants or any anxiolytics if you are able to convince the patient that you are empathetic to him, that you are going to do good for him.
Thank you, Dr. Virmani, sir.
Thank you so much, sir. And I would request Dr. Virmani, sir, to kindly remain with us as we have got a flight to catch. So, without any further ado, I would request the Honorable Chairperson of this particular session, Dr. Shyam Narayan Prasad, sir, to kindly honor and felicitate Dr. A.K. Virmani, sir, who was one of the speakers for this particular session. I would request all the chairpersons to kindly join Dr. Shyam Narayan Prasad sir, in order to honor Dr. A.K. Virmani sir, and let's have a huge round of applause for this. It's been a huge honor and delight for each one of us to have you over here, sir. And once again, I would like to congratulate you, and I would like to hand over this session to our moderator, who is Dr. R.R. Chaudhary, sir. Thank you so much.
Now I'd like to call Dr. S.C. Jha. Please introduce.
I would like to invite Dr. Pramod Kumar Singh, Bugusarai. The topic is diabetic kidney disease. What's new?
Dr. S.C. Jha is the next speaker, and we all know him. He is a brilliant orator. He is Associate Professor of Medicine at Darbhanga Medical College, and he has keen interest in different aspects of diabetes. Today he will be discussing a very interesting aspect, that is intermittent fasting in diabetes. So I request Dr. S.C. Jha to go ahead with his deliberation.
आ रहा है दूसरा उसमें हाँ तो डिस्प्ले दीजिए Honorable Moderator Sir, Professor R.R. Chaudhary, Chairpersons, our Founder President A&I Sir, respected seniors and dear friends. Today we are witnessing a huge paradox. On one hand, there is great advancement in the knowledge of non-communicable disease, obesity, diabetes and all. On the other hand, we are seeing a great epidemic of obesity, diabetes and other non-communicable diseases. So serious introspection is needed. Somewhere down the line, we are missing something. And that is why human being, we all have been probing and searching newer methods, novel methods for our fitness, for reducing obesity and for controlling our health. There are needless and a huge number of methods which have been tried. But why it is that, despite so many controversies, the concept of intermittent fasting has caught the imagination of entire world, non-scientific community as well as the scientific community, doctors and non-doctors alike. Evidences so far are very limited. In fact, they are limited to the rodent studies. Rodent studies have shown effect of intermittent fasting on the metabolic outcomes and in weight reduction. But as far as the human evidences are concerned, the situation is not that good. We have very little evidences to test so far. However, net is overloaded with literature showing anecdotal experiences. These are the celebrities in Bollywood who are claiming to have benefited from intermittent fasting. And I am quite sure some honorable members of this august audience might be trying intermittent fasting. Our colleagues are trying. What is intermittent fasting to start with? Intermittent fasting in the purest form, it is not a diet like paleo diet, keto diet, etc. It is actually the pattern of eating, cyclical pattern between eating and fasting, and various schedules have been suggested. That was in the purest form, but later on, gradually calories and proper composition have also been incorporated into the concept. Non-calorie drinks may be used during a fasting window. Now, this concept of intermittent fasting, is this a new one? No. It has been practiced since very ancient times, not only by one religion, by all different religions. We have different sorts of fasting. And these are the intermittent fasting regimes, which due to paucity of time, I will not go into details of all of them, but we will directly come to some of the most popular methods. 16-8 method is the most popular method which is being practiced. 8-hour eating window, 16 hours fasting window. 5:2 diet, 500 to 600 calories twice a week. Eat, stop, eat that, 24 hours fast once or twice a week. Warrior diet, that is just one meal and all calories within, say, just 4 hours. Now these are the potential mechanism. The thing is, the question is, why in first place we are trying a theoretical thing? Because it has got a strong theory. Number one is the metabolic switch. When we fast for more than 12 hours, what happens? The depletion of glycogen stores in the liver occurs, and after that, in the next phase, adipose tissue is broken down into free fatty acids. Therefore, there is reduction in the adipose tissue. There is reduction in insulin resistance. And autophagy is a normal process by which old, damaged and dead cells in the body are routinely replaced with new ones, and it promotes cellular repair and autophagy. And it has got good effect on the clinical and metabolic parameters. So what are the factors hypothesized to link intermittent fasting and health outcomes? They are the circadian biology, the gut microbiome, modifiable lifestyle behaviors. And violating these biological and these physiological systems can produce a hostile metabolic milieu which can give rise to non-communicable disease. This is the photograph showing the same. Now, circadian biology is a very important thing. All organisms have evolved an endogenous circadian clock over a period of evolution to ensure that physiological processes are performed at a particular best time. In mammals, the master biological clock is suprachiasmatic nucleus of hypothalamus, which is entrained to the light and dark stimuli. Remember the ancient man, he used to hunt all day around and he used to sleep in his cave comfortably after the sunset. And that has entrained our biological clock. And this biological clock is present in peripheral tissues also. And when this is broken, diseases are there. So this is the picture showing that a particular thing is being done best at the particular time. We have got the maximum strength, muscular strength, say around 4 p.m. Melatonin starts around 8 p.m. and the highest possibility of death is in the wee hour of the morning, so on and so forth. This picture shows that during wet period or feeding period, these functions, certain functions are more common, and in sleep and fasting period, other functions are more common. So the timing of food is also important.
And when it is best, intermittent fasting is synchronized with the biological rhythm, it gives the best result. Friends, insulin sensitivity decreases throughout the day and into the night. That is why meal taken at night, they are associated with greater postprandial glucose and insulin exposure. Gut microbiota, there was a good talk in the morning by Dr. Singhal sir, and this intermittent fasting helps this gut microbiota also to improve the outcomes. A small study of 8 overweight young adults found that increasing the nightly fast duration beyond 14 hours resulted in statistically significant decreases in energy intake and weight, improvement of sleep satisfaction, satiety at bedtime, and energy level was noticed. Naturally, when the fasting window is more and eating window is less, the energy control will be there. But one caveat is there should not be the compensatory overeating. And one study showed that even a one-day fast or 75% calorie restriction showed calorie intake reduction by approximately 30% during the subsequent 3 days. So this in the rodents, it has been seen that locomotion improves and circadian activity rhythm also improves, an indicator of overall rhythmicity. Data in human sparse. Nighttime eating is associated with reduced sleep duration, poor sleep quality due to desynchronization of circadian rhythm, which can lead to insulin resistance and increased risk of obesity, diabetes, and other non-communicable disease. Intermittent fasting synchronizing with circadian rhythm may reduce the risk of these non-communicable disease. Do intermittent fasting can we recommend for all? No. Pregnant women might affect the blood sugar level, baby development, etc. People suffering from heart problem, high blood pressure, electrolyte imbalance, and other medical conditions can occur. Children, adolescents, they should not be tried. And not suitable for those who have eating disorders or disordered eating patterns or any psychiatric problem associated. Now, $1 million question is whether a diabetic can fast. The American Diabetic Association for now doesn't recommend fasting as a technique for diabetes management. However, a consensus nutrition committee by ADA has commented that intermittent fasting may help in weight reduction. However, its impact on glycosylated hemoglobin is debatable. Friends, there are some studies which suggest fasting may be helpful for people with diabetes, particularly diabetes of less than 5 years duration, but it is not the mainstream treatment. One question I want to ask you all. You all are the knowledgeable experts in the of the different parts of the state and the country. Of all modalities of the treatment, which are the most effective one? Number 1 is the bariatric surgery. Second is the calorie restriction. And in some cases, remission have also been reported. So what is the message? The message is the treatment and prevention of diabetes mellitus may not be lying in pumping billions into the new drugs, but in lifestyle modification, and particularly calorie restriction is very important. Of course, it becomes more powerful when associated with exercise also. So there was a very small study of 3 patients by Jason Fung and others. And this case series documented 3 patients referred to the intensive dietary therapy clinic in Toronto, Canada for insulin-dependent type 2 diabetes mellitus. And they showed that if therapeutic fasting can reverse insulin resistance, resulting in cessation of insulin therapy and maintaining control of blood sugars. They were able to lose significant amount of body weight, reduce waist circumferences, and reduce their glycosylated hemoglobin level. We are not going into details of characteristic. Here was another study. For 1 week, the patients were put on 25% of the calorie intake, and later on, the effect was seen even at the end of 4 months. Now, intermittent fasting, if practiced in diabetes, healthcare provider, expert, nutritional expert should be there. Medicine adjustment should be there. Hypoglycemic drugs and insulin should be avoided because of high chances of hypoglycemia, and glucose monitoring is a must. Fluid intake, there are many molecules, SGLT2 inhibitor, this risk dehydration increases, and we have to convince the patient that even in the fasting time, you can go for the non-calorie drinks. The patient need to reduce or withdraw their intake of diuretics, SGLT2 inhibitor, and regulate antihypertensive medications on the days of fasting. Now, there was a small study of role of nutrition mitigating the effects of COVID-19 from effects. Ramadan, though it is not synchronizing with the biological clock, but is still intermittent fasting during Ramadan, the studies have shown the clinical and biochemical improvements. Now the question is, are all fasting regimens same? Can it be prescribed to all? Is it a panacea for all this non-communicable disease? In one study published in JAMA in June 1, 2017, around 100 patients were categorized into the 3 patterns: normal pattern, reduced calorie intake pattern, and intermittent fasting pattern. An intermittent fasting pattern and the generalized calorie intake pattern, they showed the similar result. Both diet plans had similar weight loss, and notable point was there was 38% dropout. A tendency to reward after accomplishing hard work was there. There may be a strong biological push overdrive of appetite hormones and hunger centers. Side effects reported in some patients are hunger and cravings, headache and lightheadedness, fatigue and low energies, digestive enzymes, dehydration, bad breath, sleep disturbances. The important thing is the benefits and risk in human remains largely unexplored. This is the area where exploration is needed. There is a ton of promising research done on fat rats, but they are rats. But again, one thing is there, even rats are mammals. So it is likely to be effective in some humans. One size doesn't fit all for human beings. And human suitability to a particular regime depends on the individual characteristic. May not suit persons untuned to fasting. There are persons who will require food every 2 hours. Good evidence from epidemiological study, pilot interventional trial, and few randomized trial does suggest that benefit of fasting outweigh the potential harm in an average individual. With medical supervision, proper education and support, compliance seems to be good. Some evidence to suggest superiority of circadian rhythm fasting approach combined with healthy lifestyle and exercise. Diabetics should try intermittent fasting with utmost precaution and under careful medical supervision. With proper adjustment and self-monitoring of blood glucose, the intermittent fasting can be encouraged safely in the diabetics, particularly during the early phase. Friends, old concepts do change. Strong theory yesterday, practical points today. And remember, once we believed that the earth was flat, people believed that arteries contain air. Intermittent fasting holds promise for a good health in appropriately selected patients. Good evidence-based studies, however, with open minds are welcome. Seems on a debatable ground today, but maybe tomorrow it will emerge an evidence-based powerful therapeutic tool against obesity and non-communicable disease. Thank you.
Thank you, sir, for this wonderful presentation. If there are any questions from the house, we can take 1 or 2 questions. Thank you, sir. Since there are no more questions, we will move on to the next speaker. And with a great pleasure, now I invite
Dr. Jha, is there any rule for intermittent fasting? Is there any rule? नियम, कोई नियम है intermittent fasting की?
Yes, sir. No, sir. Different types of rules are there, and there are a lot of rules being followed, lot of regimens being followed. I have talked about this 16:8 fasting mostly in suiting the circadian rhythm. But there are different types of literature, and paucity of literature in human is because of these different types of regimen. The difficulty in selecting the control group and the experiment group. But one thing is certain, in human being, there are different patterns. There are early risers, there are late risers, which we say in fun. Some people are owls, some are larks. So one regimen may not suit other. So it is one thing which has got a strong theoretical background, and it needs to be researched. Many of our colleagues are also practicing to good effect.
So it is believed that intermittent fasting promotes improved body composition, lowers disease risks, and can improve brain functions. But there are negatives also. It's very difficult to continue for long.
Yes. Now, one thing I will like to say in this regard, there are people who will go on working on, and hunger doesn't matter to them.
And
there are some people who are foodie. They will require food, sir. Might have seen particularly ladies, they do 2 to 3 fast every week, and they are still comfortable. And there are persons who are, if they are not getting food more than 4 hours, they become hungry. So one size doesn't fit all. You have to select the carefully appropriate person who will take benefit of this.
And it is also said that this disrupts your social life. Why? आज आप फास्टिंग में हैं, आपके दोस्त ने आपको जन्मदिन में बुला लिया है. You will go there and will say, no, I will not eat it. This will disrupt your social life. Anyway, yes, intermittent fasting is good. So far your health promotes. So whenever you have to adopt intermittent fasting, if you have any comorbidities, you consult your doctor and then continue. Thank you, Dr. Jha.
Thank you, sir.
Sir. Just 1 minute. I give you a scenario. A person on insulin, not control otherwise.
Yes, sir.
A diabetic person on insulin, his diabetes not control otherwise. He has to take insulin. Say for example type 1. Still you will suggest intermittent fasting?
No, sir. Definitely not. People who are on insulin dependent diabetes, and people who are taking secretagogues, they are at high risk of hypoglycemia. For all the complications which are being talked about, hypoglycemia is the most dreaded one. Because of amount of just 15 grams of glucose, the patient may die. And this is simply intolerable that in this today's world, people should die from hypoglycemia. People with insulin, they are at high risk of hypoglycemia. So at this point of time, it is not advocated.
Dr. Jha, just I extend the same question to another level. If a diabetic patient you suggest intermittent fasting, and he is very keen to do it, and patient is on oral drug, how to modify the treatment in that situation?
How to modify the oral drugs?
Is there any guideline, any rule?
One thing is for sure, sir, that this secretagogues, meglitinides, sulfonylureas, this should be avoided. In particular, sulfonylurea should be. Meglitinide you can give for short period of time because mechanism of its duration of action is very less. But sulfonylurea is definitely a big no. And at the same time, education of the patient is very important. If a doctor is trying, he may be aware of so many things. There are persons who by their Google literature, by consultation with doctors, they know a lot, they are interested in knowing a lot. But majority of our population, they are not very much aware, they are not very much educated. In those we just can't try, and this effect is mostly those studies which have been done in diabetes, they have been done in diabetics who have got 5 years or less in duration. Later part we doesn't know. And what I believe that intermittent fasting should be tried by only those people who suits them. There are people who enjoy intermittent fasting.
Dr. Jha, please stop. Please call Dr. Pramod Kumar Singh.
As we move on to the next talk, diabetic kidney disease, with a great pleasure, I invite Dr. Pramod Kumar Singh from Bugusarai, who is also the current chairman, Ccdsicon, Bihar, Jharkhand, and also the organizing chairman of this scientific session. Please welcome, sir.
Okay. Good morning to all my colleagues. My respect to moderator Dr. R.R. Jha, Dr. Shyam Narayan R, who has come on my single request all the long ways from Bihar despite his busy schedule. Dr. Lohani, Dr. Pankaj, Dr. Deepak, Dr. Singhal, whom I used to see at Tataman Hospital since my student days. It is very fortunate to have them on this dais, and Dr. N. Rai, sir, under whose shadow this organization is growing. Now come to the topic. Diabetic kidney disease. Dr. Rai was telling me that you have become interested in kidney diseases. I told him on this date I have very few patients in my indoor, but 3 of them has renal compromise. So, number 1, last. Diabetic kidney disease it is very fast, it is a very vast chapter, and to navigate through is like crossing the Panama Channel in a very short time. So what is new? I will like to concentrate because everyone knows about diabetic kidney disease. But what are the new advancements in this topic? Diabetic kidney disease is a microvascular complication of diabetes where the kidneys fail to perform adequately. DKD is a complete and heterogeneous disease with numerous overlapping etiologic pathways, including changes in glomerular hemodynamics, oxidative stress, inflammation, and interstitial fibrosis and tubular atrophy. Every word, every terminology is very important. It is the most common cause of CKD and interstate renal disease. Etiopathogenesis. Hyperglycemia results in production of advanced glycation end products, AGE, and reactive oxygen species. These two terms, advanced glycation end products, there are glycation end products like glycosylated hemoglobin, but these are advanced glycation end products by exposure to sugar of protein or fat for prolonged period through non-enzymatic or oxidation process. Toxic end products are made, and these are very harmful to the body system. And reactive oxygen species is a normal finding, normal constituent of body metabolism in very small amounts, but in diabetic milieu it gets more and more. That is free electron in the last orbit. which are there to misguide and induce unwarranted, harmful chemical reactions inside body by different cell-to-cell interactions, DNA and RNA degradation. These active intercellular signaling for pro-inflammatory and pro-fibrotic gene expression with production of host of mediators for cellular injury. While hyperglycemia surely plays a central role, hyperinsulinemia and insulin resistance may also incite pathogenic mechanisms. Ultimately, alterations in glomerular hemodynamics, inflammation and fibrosis are primary mediators of kidney tissue damage through the relative contribution, though the relative contribution varies from person to person. First comes the glomerular hemodynamics. In etiopathogenesis, the diabetic milieu activates RAS and other mediators, triggering kidney hypertrophy, increased renal plasma flow, and increased filtration fraction, which leads to abnormally elevated GFR. In early stages, there is reduced afferent arterial resistance due to anti-natriuretic peptide, nitrous oxide, and prostanoids, along with deficiency of resistance of insulin. By contrast, increased vasoconstrictors like angiotensin II, thromboxane, and endothelin-1 increase efferent arterial resistance. Result is high intraglomerular pressure, and it triggers high GFR and ultimate sclerosis, inflammation and sclerosis. Diabetes is also associated with reduced delivery of sodium to macula densa, as the PCT is hypertrophied early, leading to upregulation of SGLT1 and 2. This leads to increased absorption of sodium and glucose in the decreased delivery of sodium to macula densa via the DCT. So, DCT, macula densa feedback, there is a misconception of the system that there is low sodium, so filtration is low. So afferent arteriole is dilated even more and efferent is constricted. So there is a vicious setup leading to damage to the glomeruli. Diabetes is also associated with reduced delivery of sodium to macula densa, as the PCT is hypertrophied early due to upregulation of SGLT1 and 2. Now, SGLT2, we should know how these new molecules, drugs act. SGLT2 inhibition leads to decreased absorption of glucose and sodium, thus increasing distal delivery of sodium to macula densa and restoring the tubuloglomerular feedback. That is the mechanism of action of all these SGLT2 inhibitors that has proved to be the game changer in the management of diabetes these days. And there is reduction in the glomerular filtration, so load on glomerulus is decreased. That is beneficial for the system. This is the pictorial representation of macula densa, glomerular apparatus, afferent and efferent arterioles of glomerulus, and different factors for increased glomerular filtration. I would like to emphasize the major dominant factor of this system is afferent arterial dilatation. Efferent constriction is of lesser importance, which lead to diabetic glomerulopathy. Innate immunity and oxidative stress and inflammation everywhere. Innate immunity plays a role. A person might have very badly managed diabetes, but may not develop diabetic kidney disease, and other may have good control of diabetes. Despite all this, he may develop diabetic kidney disease. It depends upon his genetic makeup. So innate immunity is important. Hyperglycemia as well as insulin resistance and dyslipidemia cause increased formation of AGE, which upon binding to receptors located on multiple cells of kidney lead to production of cytokines. Oxidative stress and inflammation are tightly intertwined. One begets another. Macrophage infiltration is hallmark of TKD, the magnitude of which correlates with worsening of the disease. Macrophage can be activated by various angiotensin II, hyperglycemia, stress, AGE, kidney injury molecules, etc. It results in increase in oxidative stress and production of injurious cytokines, which leads to renal hypertrophy, podocyte and tubular epithelial cell injury. This is the mechanism. Innate immunity, as already I have told, in the genetic background that plays the role, but hyperglycemia per se leads to glycation and oxidative stress, intercellular signaling error and metabolism going into disarray. There is glomerular hyperfiltration and mechanical stress on the glomeruli, leading to different cascade of inflammatory pathway and pro-inflammatory cytokines, and ultimately the expansion of extracellular matrix, glomerulosclerosis and interstitial fibrosis. Hyperglycemic environment and angiotensin II lead to TGF-beta production by meningeal cell, decreased production of matrix metalloproteinases. These metalloproteinases lies the proteins in the interstitial tissue which are less there and lead to increased matrix and glomerular extracellular meningeal cell proliferate. So ultimate result is meningeal cell hypertrophy and matrix accumulation. Interstitial fibrosis and tubular atrophy. Previously, initially it was thought that the main mechanism of diabetic nephropathy is glomerular factor. But later on, it has been shown that tubular changes start to appear even before, in some cases, glomeruli develop the diabetic signs, and by virtue of higher constituent weight of these tubular tissues, even a little change is magnified to a higher effect. So these are very important factors for diabetic nephropathy, interstitial fibrosis and tubular atrophy. As decade progresses, there is a clear relationship between IFTA and decline in estimated GFR. Hyperglycemia leads to shunting of glucose through hexosamine pathway and increased production of TGF-beta and plasminogen activator inhibitor molecule 1. Damage to PCT and AGE, angiotensin II and albumin leads to conversion of pericyte into myofibroblasts. Pericytes support the peritubular capillary plexus. They are supportive there, but when these toxic materials come, they drop and begin to act in another way by converting into myofibroblasts. Like many political institutions these days, those who are supportive change their role and negative role, and that is the story here also. So these myofibroblasts start the fibrosis, infiltration of macrophages, excess of collagen and fibronectin deposition. Epidemiology and risk factors. Diabetes is the leading cause of CKD and CKD worldwide. The burden of DKD is high, leading to decreased quality of life and increased rates of disability and premature death. The prevalence of moderate to severely increased albuminuria decreased from 20 to 15%. By advancement in this field, previously albuminuria was 20% in cases of diabetic nephropathy, and EGFR detection was 10%. But nowadays both are 15% and 50%. As albuminuria percentage decreased, but EGFR loss increased. CKD awareness among people with diabetes is very poor. Even in countries like USA, a person in third stage of diabetic kidney disease doesn't know that he has diabetic kidney disease. DKD is common cause of ESKD, but the incidence of ESKD among diabetic patients is uncommon, as most of them die before requiring kidney replacement therapy. They are shunted through cardiovascular death window. This was an Indian CKD study in which diabetic kidney disease was shown to contribute to 25% of all CKDs. Majority of CKD patients do not have severely increased albuminuria. So, decrease in eGFR is more common in our country, in the southeast region. Nearly 1 in 2 patients with type 2 diabetes mellitus have CKD in Indian OPD setting. This may be alarming to see, but when you investigate every diabetic patient, the truth will come forward. Once CKD is set in, there may be fast CKD progression, and many factors lead to this situation where there is diabetes in CKD. The deterioration is more faster, about 25%. When there is no diabetes, it will be about 14%. So there is a net decrease of 11% if you have diabetes. And other factors like elevated systolic pressure, smoking, heart failure, prior ischemic stroke, LDL-C level less than 60, and advanced age and tobacco use. These are the things which lead to fast DKD growth. Complications of CKD contribute to high morbidity, premature mortality, like all these things here. And most people only think about avoiding dialysis, but most people with CKD do not survive to ESKD. 13%, in 13%, 12 die before going to dialysis with other causes, most prominently due to cardiovascular cause. Then comes the management. Diagnosis is the first stage, eGFR less than 60 or urinary albumin-creatinine ratio more than 30 is DKD if no other cause is likely. This is the staging of DKD or CKD depending upon GFR and albuminuria. KDIGO guideline for management of diabetes: first diet, general lifestyle modification, exercise, smoking cessation and weight loss. Then first line drugs, metformin, SGLT2 inhibitor, RS blockade and statins, and then GLP-1 receptor antagonist, etc. already shown in it. I will tell it later. Blood pressure control, glycemic control, lifestyle changes, lipid lowering and dietary protein restriction. Blood pressure control is of utmost importance. Blood pressure should be controlled to the lowest tolerable level. It is always beneficial. This doesn't hold good for blood sugar control, because blood sugar control, when we strictly control the blood sugar to the normal, hypoglycemia is a risk factor in DKD patients. So blood pressure targets are there. Then glycemic control, it should be modified as per age and stage of the DKD, and lifestyle modification is always important. Lipid lowering, atorvastatin is the drug of choice, rovastatin also, because it doesn't need those adjustment in raised CKD status. Angiotensin inhibition was the first thing to change the scenario of DKD, whether it is AC inhibitor or ARB. It has always proved to be beneficial in different robust studies. SGLT2 inhibitors decrease the DKD regardless of the degree of glycemia control. If you put the SGLT2 inhibitor, even if blood sugar is not controlled to the optimum, the DKD progression will be less. So, with the dose SGLT2 inhibitors, side effects. Then Ccdsicon trial showed that even if you have no diabetes, it decreases the DKD in all the patients of diabetes or non-diabetes. Credence trial showed salutary effect of canagliflozin. Empagliflozin showed that even your GFR is up to 20 ml per minute, it is beneficial in diabetic as well as in non-diabetic patients. So Empagliflozin trial, these are different parameters of the beneficial effect of these SGLT2 inhibitors. Now the new player, Finerenone, non-steroidal selective MRA, has come into play, and it is a very promising drug. It is available in India also, imported by Zydus, and it decreases the kidney and heart failure, kidney deterioration and heart failure both. So there was a trial, Fidello and Figaro DKD trial, which proved its point of reducing the mortality and the morbidity. If blood sugar is not controlled by the previous mentioned drugs, glucagon-like peptide 1 receptor agonist like liraglutide, semaglutide, etc., has been shown to control the blood sugar by surrogate markers like albuminuria. There are trials out of which liraglutide has shown persistent promising positive reports. Monitoring therapy every 6 months, BP, blood volume, GFR, serum potassium, HbA1c, and evaluation of albumin and total protein restriction, and elevation of serum creatinine of as much as 30 to 35% above baseline that stabilizes within first 2 to 4 months of therapy is considered acceptable. And no reason to discontinue therapy with these drugs. BP should be assessed regularly. So there, due to fall in GFR, the serum creatinine may increase, but it will stabilize. So there should be no hurry to stop these drugs. Monitoring both RS and SGLT2 inhibitors may increase the risk of hypertension, but first antihypertensive should be moderated before stopping these drugs. Volume depletion is also a problem, but other drugs should be stopped before stopping these drugs. Reasons for referral are there to nephrologist. Prognosis: a substantial proportion of patients with DKD will have progressive loss of kidney function and will develop ESKD. Strongest factor is presence of albuminuria, while patients with reduced GFR or anemia are also at an increased risk. These are several drugs and several trials in 2024. Flow trial will come, and this is the treatment algorithm already told. And these are the factors which are increasing the time interval between intestinal disease and developing DKD, blood pressure control, blood pressure and RAS inhibition, SGLT2 inhibition and MRA. That is like Finerenone. So take home message. We have come a long way in the treatment of DKD, and the facts and figures show for it. From 1993, when AC inhibitors were discovered for their ability to slow down the progression of kidney disease, to adding ARB to the list a decade after, later followed by milestone event of finding the evidence that SGLT2 receptors, inhibitors, GLP-1 agonists, and Finerenone could also do the same. The scene has changed by leaps and bounds. The four pillars in work in complementary fashion to slow down disease progression. As a result, we have been able to slow renal function decline from approximately 10 to 12 ml per minute per year in 1980 with no specific therapy, but now about 2 to 3 ml per minute per year. You should know that average loss of kidney function in people without kidney disease or diabetes is about 0.7 to 0.9 ml per minute per year. So there is drastic improvement. 10 to 12 ml per year means that by the time 6 to 7 years you are finished. But these days it has come to 2 to 3 ml. And we hope that with prudent management, days are not far that we will reduce this to the even lower level. So
Thank you, Dr. Pramod. Since everybody is waiting for lunch, we will not have any question. Prevention is the only measure to prevent chronic kidney disease. And no drug, what to say of newer drugs, can revert chronic kidney disease. Thank you, ladies and gentlemen. Thank you, chairman. Now the organizers, please facilitate.
Thank you so much, sir. And I will request all the dignitaries to kindly remain on the stage, since we are going to have a very small felicitation ceremony over here. And I would now request Dr. K.K. Lohani, who is the chairperson of this particular session, to kindly come forward and honor our speaker, Dr. Sudhir Chandra sir, who has come all the way from Darbhanga in order to speak in this particular session. And let's have a huge round of applause for Dr. Sudhir Chandra Jha sir. Once again, a very warm welcome to you, sir. And I would request our honorable chairperson, Dr. K.K. Lohani sir, to kindly honor and felicitate Dr. Sudhir Chandra sir. And let's have a huge round of applause. एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से, आप सभी देख पा रहे हैं डॉक्टर के लोहानी जी इस वक्त डॉक्टर सुधीर चंद्रा जी जो कि इस सत्र के वक्ता रह चुके हैं, उन्हें सम्मानित कर रहे हैं। वाकई में एक बहुत ही सुंदर दृश्य है हम सभी लोगों के लिए। और अब मैं अनुरोध करूंगी डॉक्टर एनसी सिंघल सर, जो कि इस सत्र के माननीय चेयरपर्सन के स्वरूप में हम सभी के बीच उपस्थित हैं। मैं उनसे अनुरोध करूंगी कि हमारे बीच हमारा आज के सेशन के वक्ता डॉक्टर प्रमोद कुमार सिंह सर, जो कि बेगूसराय से हमारे बीच हैं, उपस्थित, उन्हें भी सम्मानित करें। एक बार शानदार तालियां आनी चाहिए आप सभी लोगों की ओर से। और बहुत ही बेहतरीन, बहुत ही ज्ञानवर्धक सत्र रहा ये हम सभी लोगों के लिए। मैं आप लोगों से यहीं बने रहने की विनती करूंगी। और अब मैं हमारे आज के इस सेशन के मॉडरेटर माननीय डॉक्टर आर चौधरी जी से यह अनुरोध करूंगी कि हमारे आज के इस सेशन के चेयरपर्सन डॉक्टर श्याम नारायण प्रसाद सर, जो कि बिहार शरीफ से हमारे बीच आए हैं, उन्हें सम्मानित करें। एक बार शानदार तालियां आनी चाहिए सभी लोगों की ओर से। और तालियों में ऊर्जा की कमी हो गई है, थोड़ी शानदार तालियां सभी लोगों की ओर से। और अब मैं डॉक्टर आर चौधरी सर से रिक्वेस्ट करूंगी कि वो डॉक्टर के लोहानी सर, उन्हें सम्मानित करें। एक बार शानदार तालियां। I would now request once again our honorable moderator to kindly honor Dr. Deepak Kumar Singh sir, who is the honorable chairperson for this particular session, who has come all the way from Bugusarai. And I would now request our honorable moderator Chaudhary sir to kindly honor Dr. Gagan Gunjan sir, who is also the honorable chairperson for this particular